Okay. Good morning, everybody. I believe we're now on transmission mode and recording. So welcome to our July board meeting in public. Delighted to welcome a number of colleagues in the public gallery, including governors, of course. So I really hope you get some interesting things out of this meeting. We'd be delighted, any governors who are watching, to follow up on the meeting with any questions that you'd like to ask. So today we do have a number of apologies. So Dr. Itai Motumbike, our medical director, David Williams, Chris Oakes, our director of HR&OD, Joanne Lancaster, Associate NED, and David Mayer, our Deputy Chief Executive and Managing Director. We have got a number of colleagues covering various items. I particularly wanted to welcome Deborah Callahan, our newish Director of Workforce. Debs, I can't remember. Is this your first board meeting now?
It is, yes. I'm nearly 4 months in now. Yeah,
Okay.
but it's my first board meeting.
Well, welcome and good to
Thank
see you here covering for Chris Oakes. And I believe that Banu will be here at points, but I know he's got some clinical commitments today, so he may not be able to stay for the whole meeting. And of course, Banu Chadlavada is our Deputy Medical Director. So without further ado, we'll move on to the other items on our agenda before we start our patient story. So any declarations of interest for items on the agenda? I'll take that as a no. So minutes of the previous meeting, which is paper A, from our meeting of the 25th of May. So first of all, any points of accuracy regarding those minutes? Pause a moment in case anyone wants to highlight anything. Always conscious there's a lot of pages to go through if anyone wants to bring my attention to an inaccuracy. In the absence of any indications to the contrary, we'll take those minutes as approved and accurate. So we'll move on to any matters arising from the minutes and indeed the actions on the action sheet. So if there are any matters arising, please do again raise your hand. Otherwise, I think looking at the minutes, which is the action sheet, which is paper B, I think all the actions on there have now been closed, so there's nothing further to follow up on. But Julia, would you like to come in?
Thanks, Krishni. I just wanted to let people know that last week we actually had a really good workshop with our governors, where Saqib talked through assurance on the financial accounts and I talked through assurance on the quality account, so relating to that action from Quality and Safety Committee. So governors came up with some really good suggestions for next year and being involved in that quality account, which I know are going to be taken forward. So I just wanted to add that in. Thanks.
Thank you. Thank you very much, Julia. And just to note, Banu is, of course, our acting medical director at the moment in Itai's absence, as he's obviously taken up that role as deputy medical director, stepping up. So thank you. We've dealt with item 6, so we move on then to our patient story, which is introduced by Anne Rackham, our Chief Operating Officer. Over to you then, Anne.
Thank you, Krishni. I'm really pleased to welcome Natalie Baker and Beth Johnson, who are from our Talking Therapies service. And this really came from a service visit that myself and Julia did some time ago when we went to visit Talking Therapies service, formerly known as IAPT, so people know it's a national change to the name, just so people know who we're talking about. And I think we were just quite struck really in that time, not only about, which I was aware of, the vast number of people this service touches, how many people access service each month, and how important that talking therapy is for people, but also with such a big team and network of staff. We are under, as we know, increased pressure on targets for this service. It's one of our probably highest targeted services. And we were just talking about that dilemma of how you really focus on targets, but also support and develop staff. Some of you will remember from some years ago, we had some really poor staff survey results for this area for that very reason, because you're asking people to be really challenged by our access. And this service really have had some innovative ideas on how to support staff. So Natalie is an operational manager and Beth is a peer support worker. So we're going to get some sort of staff experience and some lived experience in their story today. So I welcome you and hand over to yourselves.
Thank you very much for the opportunity to speak with you all today on behalf of myself and Beth. I do have some slides that me and Beth were hoping to just take you through, just a couple. Hopefully you can see them. Okay. Thank you very much, Anne. The thumbs up there. So thank you for the introduction, Anne. As Anne mentioned, we're from NHFT Talking Therapies. And myself, I'm Natalie Baker. I'm joined by my colleague, Beth Johnson, who I can't wait for you to all hear more about Beth's experiences and her story later. And I'll share with you some of mine too. Just a little bit of an overview of, again, who we are, reminding everyone of what we do really as a service and the service that we're working within. And that is that we do work with anyone over 17.5 years old experiencing mild to moderate mental health distress. So the typical patients we would be supporting often come to us with difficulties like depression, anxiety, whether that's generalized or quite specific difficulties like health anxiety or social anxiety. A lot of people with stress, OCD, and trauma potentially as well, so PTSD often. And we've really expanded our provision as a service in lots of different exciting ways, partly in terms of the support that we offer that's becoming more specialist, so looking more at long-term conditions, but also looking at how we offer treatments as well. So whether that might be one-to-one, webinars, groups, computerized CBT, whether that's online or in person. And we always try and tailor our care to that individual person's needs. And that's something I'm really proud of that we do within the service, and that we also have some really great support around some of those CBT-based interventions too, which include peer support, which again, Beth has been incredible in doing. I can't wait for you to hear more about what she does. And also in the near future, we'll be having some brilliant employment support specialists joining us too, to again build on what we offer. As Anne mentioned, we are a target driven and highly regulated service, but again, something that I've always been really inspired by within our team and from the other people and colleagues that I work with is that we always all do our best to be patient focused and provide that environment where staff can thrive and progress. And I think that's something that I've always felt very positive about, and that again, where my progress has been allowed to develop in this service versus other services where actually I was often not able to actually get out of that bottleneck point where a lot of people who begin as assistant psychologists feel that they are. And again, I just wanted to share some lovely feedback as well from our patients, some of the things that they say about us and some of the feedback that they've given at this time, that has been really powerful and just shows again, even though we're highly regulated and highly targeted, we're always patient focused, and that ultimately this is what matters. So very briefly, just to talk a bit about my experience really within the team, because I have always felt supported and involved in service development and given opportunities from day one within NHS Talking Therapies. As I mentioned previous to that, I was working as a healthcare assistant, support worker, volunteer roles, assistant psychologist roles in other services, primarily inpatient settings, not entirely within NHFT. So when I first joined NHFT in 2017 as part of NHS Talking Therapies, straight away I felt instantly supported and empowered by my colleagues and the support around me, particularly our service lead, Dr. Sarah Clare. She's been incredible from day one and always involved people at every level really within our service and driving the service forwards and developing what we offer and taking those different perspectives and experiences. And that was one of the main things that really led me to think this is somewhere I really want to stay, and this is where I want to progress, and I want to be a part of this service. And I was really lucky to then be given lots of opportunities throughout the service in different roles. So I got great exposure to how the service worked in lots of different levels, really, and being involved in all of those different treatments from my roles as a senior assistant psychologist, then training to become a CBT therapist. And that was a really positive experience again for me, and being able to expand my knowledge base and again expand what we can offer really as a service and what we can do. And again, I was always offered opportunities and support to be able to do that in terms of the time to study and being able to then progress into those roles upon qualification, to then eventually progressing into my current role as a central team operational manager. And we do have a lot of progression as well within NHS talking therapies. And that's something, again, that I think is really positive, is that my story is not actually that uncommon. Really, there's lots of people within our service who've progressed in a similar way. And that's many thanks to some of the training programs that we are regularly able to offer within the service. There's lots of people who are able to then progress themselves into whether it's PWP training, high intensity training for CBT, or if it might be other therapy modalities. So it's always been a real encouraging point, I think, for NHS talking therapies, and that helps retain staff and maintain staff well-being as well, giving them opportunities to feel like they're moving forwards and progressing. And that's always been what I've really loved about working in the service, and why I'd love to keep working in the service and keep moving it forwards ultimately. We will come to a point where we can check if there's any questions at the end, but I'd love to hand you over to Beth now, my colleague, who has a wonderful story.
So thanks for the opportunity to share with you this morning. And again, my name's Beth Johnson, and I am a peer support worker with Talking Therapies, and been with the service for 2 years, just about now. And so as a peer support worker, that means that I work in the service by my lived experience. I'm trained, I did some IMROC training. That's a group that came and trains us to use our lived experience of our mental health experience, both the ups and downs of our mental health experience, and also the other experiences that we have in life, and the recovery journey that we're on. So it's not a destination in recovery, but as you can see by the map here, it has a beginning that's somewhere and an ongoing journey. And you can see the different points that I've put here on that road. They're just some of the highlights that I want to touch on today. And it's that recovery journey that I use to support other people, and I work alongside our therapists. And I want to just touch on some of those things. So when I talk about my recovery journey day to day, I touch on certain parts, and it's always with a sense of boundaries and appropriateness that I touch on my journey when I talk to patients, the staff, those I encounter on a day-to-day. So local beginnings. I actually grew up from the age of 8. I lived over the wall from St Mary's Hospital. When I was talking to my mum last night, she said, "Do you remember the time when there was the," and maybe I don't know how many people know this, but at the end of the garden, we had the temporary mortuary for a while. And we always used to joke about that. So I was very familiar with the things that went on. And my sisters, when I was growing up, my older sisters both worked as domestics at St Mary's. So there were a lot of things I was very familiar with, the things of NHFT and St Mary's and the various things. My mum was a social worker for the elderly when I grew up. There were a lot of things about caring for people in my growing up years. And then when I was 18, I moved up north, went to university, worked for 5 years in Liverpool. But as I was growing up, there were ups and downs in my own mental health journey, different experiences. Didn't receive any support for my mental health, perhaps maybe could have done, but my journey continued. And at the age of 23, I went off to New York and lived for 15 years in New York City. I followed a sense of a calling. My faith had been very important to me growing up. Different parts, it was more important to me. But at 23, I joined a religious community, and I'd be happy to talk to anyone personally more about that. But for here, I'll keep it to a minimum. But I would say that in those 15 years, I was privileged to work with many wonderful people. I worked with some who were struggling without the basic necessities of life, those who were without adequate food, shelter. I worked with people who were imprisoned. I worked with lots and lots of different people. I visited people who were in hospital, people who were dying, people who lived in the projects in New York. Loads and loads of different experiences. I had the privilege of traveling to 23 different states in the 15 years to talk about faith to young people, often emceeing retreats for young people. I also had the great gift of going to Haiti 3 times on mission after the massive earthquake in 2010, and working alongside the local people in their efforts to rebuild and in different capacities. And then in 2017, when it all came crashing down, you know, I share those experiences before because in 2017, life suddenly took an unexpected turn. I found myself returning to the UK, broken, unsure of what life held. You know, much of the previous experiences had been wonderful, but there were other parts that were soul destroying to a certain extent. This sudden ending rocked me, and you know, I'd had other therapy experiences while I was in New York, and I had some tools and I had my faith, but it was a major life changing experience that shook me to my core. I came back with the clothes I stood up in, a small amount of money, but I left my religious name behind. I lost my work. I lost my identity, my sense of identity. I lost my community, my friends, everything. I was 38 years old and I had to start again. I didn't know who I was, what I wanted to do, what was going to happen. And thankfully, I had a mum who gave me a house, well, gave me somewhere to live in her house. I lost my routine, I lost everything. And I descended into a deeper depression over the weeks and months. And, you know, there's a bit of a family history. I had my own history. I didn't want to go out. I didn't even want to get out of bed. And so I needed to start on this new step, rebuilding and self-discovery. I registered with a GP. They recommended talking therapies, or IAPT as it was then. And I started on what we have in talking therapies, the step care model. I had an assessment. I started with some one-to-one sessions. That wasn't the most helpful thing for me, although I thought one-to-one would be the best. But when I went to a group, I had what I always refer to my patients as an aha moment. Something clicked for me and it was amazing. Whatever happened in that group began a transformation for me. Just the way of challenging those thoughts worked for me. And the transition, I went from not being able to get out of bed, not wanting to leave the house, to applying for a postgraduate course. I went to starting volunteering. I started to move on in my life, and things began to change. And you know, it was amazing. It wasn't fixed overnight, you know, so I was accepted onto the postgrad. Then I decided it wasn't the right moment. And then I went into step 3 treatment after a little wait, after a bit of a wait. And there I found a great connection with, you guessed it, Sarah Clare, Dr. Sarah Clare. She was fantastic, the lead of our service. And she suggested hearing some of my experiences, getting involved in involvement as well. So I started doing some involvement work. I sat on interview panels. I did co-production as I progressed in our service. And through that, then things got even better. I then went on to do my postgrad in chaplaincy. I did 2 years of volunteering at the university here as a chaplain. And when I finished my treatment, then she said, have you I decided I needed to move away from purely church work for my own recovery journey to continue. She said, have you ever heard of peer support? And so I did the IMROC training. I then applied for the job in the service. When I heard it came up, I applied for my first paid role in 20 years and was successful. And I started working in our service, and the journey continues. So in my peer support work now, I'm able to use my lived experience of the ups and downs of my mental health. I'm able to use all my lived experience of all those people I worked with. I learned to take the good parts of what had come before and to leave those other parts behind. I was able to bring forward all that was good and move forward. And I'm able to walk alongside the therapists and my patient and the people that I work with, the peers. And I'm able to just look for those good things, those moments to engage. I'm able to look in the service and to work alongside in the service, whether it's a webinar, whether it's one-to-one, all the different aspects, and to use that lived experience to support everyone I encounter, to look creatively for moments to bring life and all my experience into every day and into every encounter. And it's been such a great experience. And I think what I love to bring into the peer support and into the service is that each person I encounter can feel valued, respected, and cared for as they deserve, as I felt and as I would want to feel, and that each person can take the next good step in their life today, whether that's a service user, whether that's a colleague, whether that's one of the cleaners in the office. You know, it doesn't matter, that each and every person can feel that they're valued. So I just wanted to share that with you today because it's such a gift. It's been such a gift in my life. And I just want you to experience that gift. So thank you so much for having the opportunity. I hope I haven't spoken for too long, but I just really wanted to share that gift with you today.
Thank you so much, Beth. It looks like there's a couple of questions.
Yeah, Natalie, you ready for questions then? Are you happy to go straight to questions now?
Sure, I'm happy if you are, Beth.
Yeah, absolutely.
Great. Thank you so much, both of you. So as is traditional, I shall now bring members of the board, I'm sure, who want to sort of comment, in some cases just comment on what they've heard, Beth and Natalie, and in other cases there might be questions. So I'll just bring people in if that's okay, and we'll have a conversation. So first of all, Scott Adams, and it'd be great if everyone could just let Natalie and Beth know who you are. Scott?
Well, hi Natalie, hi Beth. As Kirshni's just said, my name's Scott Adams. I'm one of the non-exec directors at the Trust. I was actually halfway through typing a message into the chat to just say how much it had impacted me, but it felt a little bit false, to be honest. So I felt compelled to put my hand up. So first of all, Natalie, a really clear, succinct description of you know what it is that talking therapies bring forward. And then you brought us forward your 5-star pupil, if you like, in Beth. So Beth, I mean, what an incredibly moving story. I think every time we have one of these patient stories, I'm always struck by how open and sincere people are, and how humbling it is actually to hear people talking with such openness and sincerity. I suppose what I wanted to try and recognise here, I don't really have a question, right? I just wanted to recognise the way that it's impacted on me, the way that you've just spoken, right? Because, you know, what came across as a story of a real fighter, a story of hope, right? I thought it was incredible to hear just how self-aware you are as an individual. And it struck me as well just how often people who have that degree of openness, and people who often find a sense of purpose through helping others, actually have that openness and that vulnerability that, you know, it's caused you some of the challenges and issues that you've had to deal with. But what I'm struck with, Beth, was it was a triumph. Your story's a triumph, right? And I just wanted to thank you for sharing it with us.
Thank you.
Thank you very much, Scott. Julia?
Thanks, Krishni. Hi, Natalie and Beth again. I couldn't not just come in and just say, sorry, apologies, my voice gone, but just to say, I heard a little snippet of that story when I was visiting with Anne to the service, and I was so blown away then. And the impact on people's lives that you have generally was just incredible. And then to talk with Beth and to hear how you as a service have, helped develop people. And Beth, you, as Scott says, so brave to come and share that. Well done. That was absolutely incredible. And I think you're just the tip of the iceberg from the many people who the service has helped. And, what a phenomenal thing. The impact for everybody. I think everybody will go away now and reflect and be proud. That was incredible. So thank you very much for coming and sharing, because that was only a few weeks ago we were there, and here you are. So thank you very much.
Thank you, Julia. Robin?
Hi there. Yeah, thank you to both of you again. We're all going to say the same things. I'm another non-exec. I'm also someone who has worked in therapy. And also, I just want to say to you, Beth, it's really important that people with lived experience are in the room helping people. Being part of what we do is absolutely crucial. And I'm sure, I know you're not alone in this room. There are other people here who have lived experience, whatever our backgrounds, whatever our journeys we got to here. There is a great deal of lived experience. So we can very much respect and value and welcome the contribution that people like you make. So thank you.
Thank you, Robin. Angela?
Yeah, again, same sentiments, Ashley and Beth, and a lot of courage, Beth, to share your story. I'm Angela, the Chief Executive of NHFT, and as everybody said, it's so powerful to hear stories, but it takes a lot of courage to do that. So thank you for sharing that. I was also struck from both of you that what you've captured, whether it's the career pathway of a peer support worker, and yourself, Natalie, in terms of your progression, I think is a really important story in its own right. And I just wonder whether we could do more to capture that. And I'm just looking at Deb's in terms of that career pathway, because it's such an important message for not just your stories, but also for career pathways in NHFT. And I wondered if we could do more on that, Debs, if Natalie and Beth were agreeable to that, so that we could actually use it as sort of case studies or examples, please. But thank you very much.
Debs, you happy to pick that up?
Sorry. Yes, absolutely. Sorry, I thought you could. I was assuming you were lip reading. Yes, absolutely. And I agree. We need stories like yours. Very, very powerful. So I'm happy to connect with you outside the meeting.
That's great. And certainly I was very struck myself by the sort of, the journeys that both of you described in very different ways, but Natalie, in terms of your development, and Beth, in terms of your journey with your health as well, and your own other experiences. So really striking. Thank you. Richard?
Yeah, hi Natalie. Hi Beth. I'm Richard Wheeler. I'm the finance director. Actually, Angela's stolen the point I was going to make. I was really struck with that career path, and as a large employer, how important that is for us to be able to supporting people, particularly with the cost of living crisis and difficult times for people. So the training and support sounded really great. So yeah, just wanted to echo that point. Thank you.
Thank you, Richard. And finally, Anne?
Yes, I was just going to, hi Beth and Natalie, you're obviously aware of me, but I just wanted to say that just listening again, you get a fresh aspect each time. And I think capturing that is really important. And I just wanted to sort of share with the board how the peer support worker roles across the organisation are really, really important, because that authentic openness and being able to come from a different perspective, and all of us coming from different perspectives, brings a richness to and a challenge to the way we do things. And I think that's really important. And that's where I think we should also share that sort of message across the organisation. So I'll take that away to think about some more.
Thank you, Anne. Melanie?
Hi, I'm Melanie Hall. I'm one of the non-executives as well. We've clearly all been very affected by the overall sort of perspectives that you shared. I know that, and you talk so powerfully, Beth, about how engaging with the service, changed your life. And I wonder whether you have any perspectives on, and together with yourself, Natalie, are we doing enough to make sure that people who need this service can access it? Are there any other things that you think we could do that to promote the service, to reach people who maybe are the most unreachable but the most in need? And just reflecting maybe on your own experience, Beth, of how you came across talking therapists. You clearly had a strong connection with the trust sort of through your early life, but I just wonder whether there's any perspectives you have on how to reach the hardest to reach people.
Natalie or Beth?
I mean, I think at the moment I know from my perspective, I think we're reaching out in many different ways. We're at the moment we're working on trying to expand the different ways that people are able to access the service. We've done a lot this last year or so on webinar access as well as telephone access. I'm part of working on the webinar team to make the variety of webinars available, and follow up, and working a lot on engagement. So I've been doing a lot to reach out to people who don't engage. If people don't, I work through the lists and lists of people who don't contact us, and do a lot to contact them to see if there's another way that they'd like to contact us, if there's another way. I think it's one of the great things about being a peer support worker, speaking to people, saying, is there something that prevents you from contacting us? Is there another way? Is there another method? Is there another, what is it that you would like from us? So I think that, being a peer support worker and doing that, understanding the challenges that people face has been a great, has been a great difference, something that we're trying that's different. I don't know, maybe Natalie has ideas about other things that we're doing.
I totally agree with what you've said, Beth, really. I think it's about variety of support, definitely, that's really important. I think there's always new and creative, exciting projects that we try and encourage within the service. I'm sure there'll be plenty more to come in the future, but certainly looking at how we collaborate with other services around us as well, I think has always been important, and different community groups ultimately, and trying to work in joint ways. And we've got some exciting projects that we do have in the background with different organisations like Northamptonshire Carers, for instance. Population that we know historically find it really difficult actually to try and engage in sort of structured support with the demands they have on their lives. And certainly we've got new roles coming into the services, mental health support practitioners too, who are going to be more GP surgery based and be able to collaborate within the PCNs a little bit easier potentially as well. So I think there's always lots of opportunities. And another thing that I think is fantastic that we have within the service is we have a co-production group who actually are always reviewing what we do as a service in terms of the treatment offer, but also again how we can reach people, and that's an ongoing project for that group.
Thank you very much. Thank you, and thank you for the question, Melanie. It is something I think we've tried as well to promote through our governors, Natalie and Beth, and I think we actually did a webinar yesterday on the new bit of the service, which is talking therapies for long-term conditions. So I think there's quite a few things we're trying to do, because obviously our council of governors are often members of the public and have access, if you like, to the communities. We've done some promotion work through them, so that's, I think, another vehicle for us to try and keep pushing the message that this service is available to people through their GP, but also through self-referral. So it's a really, really important point. But thank you so much, both of you. It's absolutely, as ever, inspiring to hear from both and empowerment. I love, Natalie, your description of feeling sort of empowered to develop your service, which I thought was a really powerful thing about the environment we obviously want you know, the trust to create for our staff. And Beth, your journey, obviously, as a, you know, with your mental health and everything you described, is absolutely inspiring. So thank you, both of you, enormously for everything you're doing. It's a really important service. And I'm really glad the name has changed to something that actually describes what it is, because I think it was often known by the sort of program name, if you like, rather than something that made sense to perhaps members of the public. So I'm delighted the name has finally changed, and we can describe it a little bit more effectively. So thank you for joining us, and no doubt, you know, we'll be hearing and seeing from the service again in the future. Thank you.
Thank you very much for having us.
Thanks, Beth, as well.
Thank you.
Okay, we will move on then to our next formal item on the agenda, and that is our risk section. And so we start with our risk report, which is paper D. Richard.
Thanks very much, Krishni. Good morning, everybody. I will just highlight a few things in this month's risk report, and then, as usual, we'll take any questions from board members on the individual risks. You'll see here that we've taken the opportunity this month just to set out where we've got to with our ongoing risk transformational journey, very much a sort of natural evolution of our already strong approach rather than a revolution as such. So we haven't yet completed the new transition to the board assurance framework, although we are making really good progress with this. We've got some further time in our development workshop next week to work with our NED colleagues on the new risks. So we should be bringing back to the September meeting the board assurance framework in its new guise. So in the meantime, that means that the existing risks on our organisational risk register are the risks that we are managing at a strategic level. The work we've been doing in parallel, I just wanted to highlight with the Executive Management Board. So we've been refreshing the risks, the operational day-to-day risks that the organisation is managing through the Corporate Risk Register. And we heard actually on Monday from the work that our Adult Services colleagues have been doing to refresh their directorate level risks in conjunction with the Corporate Governance team. So that work is really well underway too. So board members will probably be aware that we normally take the opportunity in the summer to review our risk management framework. But given we are in transition to the new board assurance framework, and we're likely to have some lessons learned as we make that transition, we're proposing not to do a holistic review of the risk management framework at this point in time, to make some minor changes at this point, and to hold over then a more holistic review until later in the year, so that we can then factor in the lessons that we've learned from implementing the board assurance framework. So that's really the thrust of the report this month. As I mentioned, the latest position on the strategic risks is set out in the report, which obviously colleagues can see, and I'll happily take any questions on. Also, just to highlight, we've, as usual, included the current position with the system risk register that the ICB is managing on behalf of the system as well. So with that, Christian, I would just hand back to you for any questions, also to seek the board's agreement to the proposed approach regarding the risk management framework, noting that we'll be bringing back then the board assurance framework in full in September. Thanks very much.
Thank you, Richard. Any questions for Richard on the paper and the proposed approach? Judith first.
Thank you, Krishni. May I just start by apologising if you are hearing extraneous noises. I've got builders literally outside my window as we speak. Richard, thank you very much for the paper. Really, really clear. It's the first time that we weren't able to discuss these changes at committee, so this is the first time that we're seeing this. I would suggest coming back to Performance Committee in September to understand a little bit better the two risks, the I1 and I2, which are being moved to the corporate risk registers, because clearly the way they currently worded those risks, they are quite large. And the remediation or mitigation that is proposed in the paper that you've written seems to be quite narrow. So I'm feeling that there's a mismatch between how we're remediating the very broad risks that we have defined there. Also, and this was something that we discussed in Performance Committee, currently B8, which is the finance risk, if you like, that Performance Committee specifically looks at. I'm not now clear where we are with that. I know that there are new words and a new risk being proposed that Richard has looked at and that will appear in the BAF, but currently the risk seems that it's closed. So we need to be very careful on an optics point of view, because clearly we discuss risk around finance, and I'll be reporting on that later on in this board meeting. But from an optical point of view, we need to be really careful that there is actually a financial risk that appears on our risk register at all times. So with those, that's really just a comment. Thank you for that.
Thank you. Richard, do you want to come back in on those before I move to Julia? So I think the questions were about I1 and I2, the innovation risks and the finance risk.
Thanks, Christy. Yes, and I'll probably bring Richard Wheeler in on the specific finance point. Yeah. But yes, I think a really good point you did. I think we are doing a bit of a deep dive on innovation more generally anyway, actually. So it is timely to have a look at those risks in context of that deep dive. I know that's been an area of inquiry for the committees. So I think good suggestion to bring that back into the September meeting, which we can certainly do in conjunction with colleagues in the team. And you're quite right, of course, we have a finance risk, a strategic finance risk that we'll need to be managing. So if that's not coming across clearly, we'll need to correct that. And I'll probably hand to Richard in case he wants to comment on the details surrounding that.
Yeah, thanks, Richard, and thanks, Judith. I think we've just got caught a little bit in the transition of kind of one financial year to another with our external accounts being signed off at the end of June, which obviously takes a little bit of time. But no, there is a risk that is in development, which has a very short title around risk of not delivering a break-even financial position for this year, which is the national planning ask, and our financial plan as a system was submitted on that basis. So we'll be looking at the controls and assurance around that risk, just so the board is clear and make sure that is on the risk register. But just to recall that now in the minute, that is the risk that we're focused on.
Thank you, Richard. I think that's helpful clarification. And the innovation risks, I think, Richard, you're suggesting can be picked up as you've suggested. So we have a couple more questions or comments. Julia first.
Thanks, Krishni. And yes, just as chair of the Quality and Safety Committee, I just wanted to say that we really have appreciated the continuous improvement sort of approach around our board assurance framework and the work behind all this. But absolutely agree with Judith's points that it is work in progress, and we haven't had the opportunity to go through all the risks in detail in the new format, and we will be looking at those in the next round of committees. But absolutely appreciate all the work that's gone on behind the scenes. And I was going to mention innovation, but that's been covered, because actually we cover that in quality and safety. So thanks very much.
Thank you, Julia. Melanie?
Hi, yes. Sorry, I might be slightly reiterating some of Judith's points, but I'm keen to understand when we get to the board workshop, I guess, how we make sure that our BAF risks are not so generalised and catch-all and that they seem a little generic. And I'm particularly reflecting, or have been reflecting, as I saw the kind of the categoric priorities from NHS England for the NHS, one of which being waiting lists, that our Q4 patients are unable to access services in clinically appropriate timescales just seems a very kind of non-specific description, a very generalistic risk that might sit on the BAF and is absolutely relevant. But in reality, we have probably 3 or 4 areas that I'm sure appear further down in the corporate or operational risk registers around, for example, adults and children's ADHD. And I'm just wondering how we make sure that our BAF is supported by very specific areas of risk rather than broad brush general things that we're doing. Do you know what I mean? I don't want the BAF to lose sight of some more specific, very critical areas that we are having to deal with. So it's just a sort of a thought really in terms of how we make sure that we don't lose a specific point of a problem in a very generalistic risk on the BAF.
So I mean, I'll bring Richard in on that, but I probably a good conversation to have in our in one of
Exactly.
our follow-up conversations, Melanie. I think the important thing is that obviously the BAF is intended to focus on strategic risks. There will be operational risks, and we just need to think about at the appropriate point at which risks are escalated and when they're significant enough for the board's attention, as opposed to things that the executive should be managing. So I think that's my first take on just making sure that we are focusing on the right things, but perhaps for debate at our board development workshop, because this is work to be done. But Richard, do you want to comment further?
Thanks, Krishni. Yes, I was going to say spot on, Melanie. The work we're doing is absolutely to try and make sure that we've got a specific articulated risk against our strategic objectives, and the focus of next week's workshop will be to illuminate how we're doing that. And as Richard's just mentioned, in terms of the finance one, our plan being to achieve the break even, that then gives us that sort of clarity in terms of the lineup between the objective and the risk. So yes, I think more to follow next week, but I think a point really well made. Thank you.
Can I, sorry, Krishni, just to respond to that specifically, I think that's a really good example. We have a very clear target for finance break even, and the risk is that we won't make it. We don't necessarily have a clear target defined for our risk for waiting times or waiting lists. They might vary from service to service, so it becomes more difficult to articulate where the risk actually sits, because the risk is not that. Do you know what I mean? It becomes much more difficult. So I absolutely agree. Discussion for next week and beyond, but it's about that articulation of risk. Yeah. Yes,
it is about articulation of risk, but it's also about the appropriate focus, I think, for the board in terms of strategic objectives and the risks to those. So I think there's something about just making sure we get that balance right. But I think it's absolutely worthy of that conversation when we have a little bit more opportunity to give that airtime, but definitely one for picking up. We've got a board development workshop next week, and I think the plan is to spend a fair bit of time on this, so definitely a good opportunity for us to explore that further. But broadly, I think we're saying we're supportive of the direction of travel, notwithstanding those kinds of things that we will need to resolve on points of how we develop the BAF to make sure it still feels meaningful, which I think, Melanie, is your point more broadly. So we are obviously being asked to receive the update and the updated position, but we're also asked to endorse the SEB's recommendation to make the commission a comprehensive review of the risk management framework later this year, and there are some minor amendments in the meantime. Is everyone comfortable to support that, given the amount of work we're already doing on risk management? Okay, great. Thank you very much. Right, thank you everyone for your comments. And I think there was a couple of follow-up actions there as well that reference what you did brought up earlier in the conversation. We have, I think we've dealt with the review of the risk management framework as part of that, haven't we, Richard? So it's now over to if there's anything you want to cover as far as system-wide winter planning and COVID response is concerned.
Yes, thank you, Krishni. So clearly COVID is still around, but we're not seeing the impacts currently on the pressures in our systems, which is good. As a system, we have started to think about winter, even though it's always strange, I haven't been on my summer holiday yet, but we're thinking on winter. We are due a letter we're hoping will come out to systems today from National around winter planning. But we've started already in county. We have our urgent and emergency care board, which I sit on. We have 6 defined work streams who are generating through cross-agency the sort of plans that we can put forward if we have the opportunity to develop, but also to think about how we manage within what we have. So those 6 work streams have a workshop at the beginning of September, or no, mid-September, where we'll be just looking at the position we're in, how we understand our demands and capacity, what processes we the work streams will put in place, and therefore developing up, scoping up that winter plan more. There has been, I think, a slight interesting change in how NHS England are looking at some of this. They've put in, prior to the letter, some work streams. They've asked us to look at our maturity as a system, but some work streams. And I was really pleased to see that some of those regional and national work streams will be around community and around mental health. And I think that's just a really important indicator that, you know, winter is everywhere, impacts everywhere, and it's the whole system that can enable flow. And it's really good to see that kind of work stream progress. So we'll obviously be inputting into those work streams and feeding into the winter planning process. I think that's about where we're at, Krishni. Thank you.
Thank you, Anne. Any questions for Anne? I think probably worth mentioning that there was a national webinar yesterday which preceded the letter that was due to arrive. And just really an ask, I think, Nash, from national colleagues that, you know, whilst it does feel strange to be, as Anne rightly said, to talk about winter when it feels like we're still in the middle of summer, the need to, you know, have that system-wide focus on preparations, because last winter was extremely difficult, and I don't think we can underestimate how challenging it can be. And obviously with ongoing industrial action, which we don't know what the situation will be near that point, there will be challenges. So the readier we can be and the more we work together as system colleagues to manage and respond to that, the better. So I think if there was sort of a core message around all of that, it was that really. But as you say, we are awaiting the letter, I still think. Richard.
Yeah, just I think for the board, this is really key as well from managing the financial risk across the system. There's always a large danger that we incur sort of short-term premium costs trying to manage with peaks of demand over winter, and that's why an integrated plan and the opportunity to integrate that with social care as well is key. So I'm sorry Anne hasn't been on my holiday yet, but I'm very pleased that we're planning for that now, and we'll have opportunity to scrutinise that through various committees and through the ICB as part of that. So I think that's a positive, and sounds very positive that it's including mental health and community to recognise, you know, the impact across the whole system.
Thank you, Richard. Okay. So next we move on then to our assurance report from the Integrated Assurance Committee, and Julia, please.
Krishni. So I'll take the report as read. It was just to note that this was the first occasion that the committee looked at workforce risks reports and assurance. Only one area to alert the board was around the agency spend remaining over target at the beginning of the year. But we took a great deal of assurance from the oversight, intense oversight from the executive team around the deep dive activity related to the value programme. So that was really important just to bring that. We talked quite in depth about that. The deep dive risk itself was around ensuring we have consistent, timely and accurate data. Really important risk we've been talking about for a while, particularly around improving patient care and decision making as an organisation. Just one really important sentence in there for me. We were reminded that every piece of data relates to people and families, and we just felt that was really important. Made me just rethink every time we see a report, this is about people. So it was really, really good, and just helps a different perspective, I think, sometimes on this risk. Gained a significant amount of assurance, particularly around our triangulation of data, and we had a few challenges and limitations to assurance, which we've highlighted there. And then just to remind everybody about the workforce reports, we were assured that the workforce risks are being appropriately managed, but the overall challenges and pressures remain significant and remain, especially highlighted through workforce and safer staffing reports. And then just in the Assure section, the new strategic workforce group, we were pleased to hear about their intense oversight of some of the workforce issues, and a really illuminating paper around the Agenda for Change gender pay gap, and we gained good assurance through that. So that's all, unless there's anything anybody wants to ask.
Thank you very much, Julia. Any questions or comments on that report? No, thank you very much. Okay, we now move on to our strategy section. So first of all, we have an opportunity to just hear from Angelo, any of the executive directors, just in terms of any general environmental analysis about sort of current matters that might be worth referencing. So over to you, Angela, first and foremost.
Thanks, Krishni. Again, just to highlight that the Integrated Care System has now published its 5-year plan, and that is obviously aligned to the 10-year Integrated Care Partnership strategy, Live Your Best Life. So I think, again, important, I know board will be cited, but a really important strategy that will have a lot of alignment with our own in due course as well. We've also had the CQC give us sight of changes that are happening to them as they transform, and we've got some introduction meetings coming up as an organisation with them to introduce new members of the team, so we look forward to that. We've also been cited on the fact that integrated care systems will now become inspected, and recent news was that 2 systems are likely to be the first to have that, which will be Dorset and Birmingham and Solihull. So again, it is starting to change that system inspection regime. We also know local authorities are subject to inspection, and just to say that the East Midlands network of adult social care contacted me to see if we could support them in terms of thinking about that preparation, and I'm pleased to say that Julie Shepherd, Chief Nurse, and Anne Scott, Chief Nurse from LPT, supported that. So again, an opportunity to connect with local authority colleagues on their inspections. And then the final thing just to mention is that yesterday was the publication of the National Partnership Agreement, Right Care, Right Person, which people will be, I'm sure, familiar with the focus on policing and how they are being used and their capacity. I think important to signal that national partnership agreement, but also to share with the board that through our mental health and learning disability autism collaborative, we held a recent workshop with our police colleagues, and it was a multi-agency workshop to understand how we work here in Northamptonshire. And just to assure people, we work very well here in Northamptonshire. We have very good partnership arrangements in place. I think the workshop gave us a chance to reaffirm those and seek commitment from everybody on those. And it was also an opportunity for the police to describe some of the pressures they're under, and again from a multi-agency point of view, to understand what we can do to support them. And I'm pleased to say that we had service users also with us on that workshop, describing how they experience when they're in crisis, those partnership arrangements as well. So that's all, I think. Thanks, Krishni.
Thank you. That's really good to hear, Angela, about the work, obviously the conversations with our police partners in particular, because I know that's been a sort of significant concern in other systems. So really good. Thank you very much. Okay, we'll move on to my chair's report. So just draw your attention to a couple of things. I'll take the report as read at paper F. But just to confirm really that our planning for our annual general meeting and annual public and members meeting is well underway. It is taking place on the 18th. Hopefully board colleagues will have the date, 18th of September. Board colleagues will have the date in their diaries. It will be an online event. I think I've mentioned in a previous chair's report that the theme of the meeting will be compassion in partnership. So we're sort of very much maintaining our focus on compassion, but perhaps with a slightly different lens of this meeting. And we have an active group of governors working with Judith Seymour, one of our non-executive director colleagues, to develop the agenda and make sure it sort of meets our needs. So I don't know, Richard, if you wanted to mention anything else about that meeting, or certainly welcome Judith to comment as well if she wanted to. Richard?
Thanks, Christine. Just to make everyone aware, our accounts were laid before Parliament prior to the summer recess, and they are now available from mid-July on the website. So I think as we talked through the board, there's a lot of detail in the annual report and in the accounts for people to review ahead of that meeting.
Thank you, Richard. And Richard Smith, anything to add?
No, thanks, Christine. I think it's been covered really well. Thank you.
Okay, so just ask the board to note the preparations and plans for that meeting, which obviously is a very important one for us and for our Council of Governors. I'm also looking for the board's support. There is a statement of principles associated with the paper, which is a very brief summary really of the areas, the sort of description of principles of how the board and governors work together. The Council of Governors approved that in its meeting a couple of weeks ago. It is literally a small piece of work that we did at our joint board and Council of Governors meeting, which was really enjoyable. So I think just a statement of principles on how we work together, which I would welcome the board's support for. Everyone happy to indicate their support? Great, thank you very much. Other than that, nothing else to highlight. I think we did have a really good board development session at which we talked extensively about things like freedom to speak up, which is on our agenda for later as well. So unless there are any questions, I'm going to hand over to Angela for her Chief Executive report. Angela.
Thanks, Krishni. And just to start with, an enormous thank you to all our staff and volunteers who continue to support us day in, day out. I know we've heard around COVID this morning in terms of less pressure, but I think it's fair to say that all our services remain under pressure for different reasons, and that's whether you're in clinical service or corporate services. You know, our staff and volunteers go above and beyond, and that is managing obviously industrial action as well, which we know is continuing. So enormous thank you to everybody for that. Really pleased to highlight the NHS 75th birthday, a real opportunity to celebrate, reflect and consider that, and pleased to say that people celebrated that in different ways across the organisation. I think also important to say this does represent an opportunity to consider what next for the NHS, and I'm pleased to say that through the engagement work that's gone on across the country, the report and next steps are being considered fully, and I'm part of that national group. In fact, I'm meeting today across the country with some leaders to think about what's the next steps and priorities and areas for consideration for the NHS going forward. So I'm pleased to be involved in that. Also, just to draw attention to the publication of the NHS long-term workforce plan, we really welcome that. That is, long awaited. It really does represent a significant ambition. But of course, what we need to do is translate that into what does that mean for Northamptonshire? What does it mean for NHFT? And that's still work to do, but nevertheless important that it is now publicised, which we are pleased about. Again, just to highlight in the report that we're pleased that Northamptonshire is embracing the anchor institution concept, something we've spoken about in board development sessions before, but I think that is something that we really welcome that we're part of, but pleased that others are joining in with that, and it's something we can obviously work on together. Again, you'll see in the report highlighting awards and recognition of shortlisting. Really pleased for this because a lot of effort goes into being able to be shortlisted, as well as people supporting the application themselves. Really important that we continue to support these. It boosts morale, it validates what we're doing, and it gives us opportunity to share our learning as well as to receive learning from others as well. So really pleased to have that recognition. And then finally, just to mention that this week, in fact, we had a Berrywood in Bloom competition. I was really pleased to be part of that. And this was organised by one of our therapy technicians, Richie Moore, who did a fabulous job of mobilising everybody to get behind this. And the gardens were what we focused on the Berrywood in Bloom. So all of the wards were participating in gardens, and service users, staff were involved in competing against each other. It was a fantastic opportunity. It was lovely. Unfortunately, it rained all the time. We were going around the gardens, as you would expect, but it was lovely. And we've said that this should be an annual event. It was just a real great example of co-production action. And then we had a fabulous sort of get together in the cafe to talk about what we'd seen. So just hopeful that will be an annual event going forward, and thank you to everybody involved in it. And I'll leave it there. Thank you, Krishna.
Any questions for Angela or comments on the report? Scott?
Well, first of all, thank you, Krishna. First of all, Angela, Berrywood in Bloom sounds fantastic. I was smiling a lot as you were talking about that. I just wanted to make sure I was sort of interpreting some detail in your report correctly, if that's okay, Angela. The way I've read it, I think it seems to come across that the last round of industrial action seemed to be felt more by acute colleagues rather than by us. I don't know whether I'm misreading that, and that's part of the reason for the clarification. And I suppose linked to that, I don't know whether you might want to pick this up with or bring in Richard at this point as well, but where we are with the pay rises now, do we have any visibility of whether that's going to be fully funded as it comes across to us yet or not? The old nugget in relation to that sort of stuff. So
yeah. So I think, in terms of the industrial action, I think it's probably fair to say that there is more cancellations involved in the acute sector that we see through the industrial action, but I don't think it's something that doesn't impact on us. It does. There's a lot of work that goes on to manage this situation and to make sure we stay safe, and colleagues obviously need to support that in different ways. So we have impact, but we know that the cancellations are particularly prevalent in the acute sector, which is different. In terms of the pay awards, I think Richard can come in here. I think it is, as ever, complicated, but I think Richard can comment. Thanks, Scott.
Yeah, so there's probably a number of aspects to this, so I'll do them in turn, really. So in terms of the back pay and the COVID backlog pay that was paid in, all the pay awards were paid in June to Agenda for Change staff. In relation to the back pay for the last year, and say the COVID backlog payments, the funding we received covered that award. I think it's fair to say we're still working through the details of the pay award for the current year, but actually talking to my team and talking with other organisations, there does appear to be a bit of a shortfall in funding compared to the cost that we've incurred. It is quite complicated because all of those pay awards went through at the same point, and the pension bands changed as well at the same point. So there is some detail that we're working through. We do, within the NHS contracts, we get a tariff uplift So we are following that up with all of our contractual commissioners to secure that money, and then we need to have separate conversations for non-NHS contracts with, for example, local authorities and others to cover that. In terms of the medical pay award, I know that's obviously not agreed from the junior doctors and the consultants point of view. NHS employers are saying they will issue some guidance shortly. So my understanding is the government will enact that pay award anyway at some point, but we haven't got a timing for that as yet. And we haven't got, therefore, any details of funding arrangements for that either.
Okay, thank you both. Really comprehensive answer. Thank you.
Thank you, Scott. I think I just wanted to pick up myself that there was a reference in Angela's report about the record number of doctors and nurses in now counted, if you like, in the numbers within the NHS. But of course, that does pose a different question then around productivity, which has then become a significant challenge. And I think it's sort of important for us to focus on that. My sense is that's predominantly in the acute sector, because the increases in growth in the mental health sector have tended to be through the Mental Health Investment Standard and development of services. It'd be interesting to get a comment on that, Angela or Richard, just because I think it's an important, very topical issue, and there's actually a feature on one of the HSJ articles, I think, this morning about productivity. But I also just wanted to pick up that again, because it's in your report about the new talking therapies service on the long-term conditions, which I think is just worth highlighting again, because that's a really important development. And actually, we did have a webinar for members in the public to attend yesterday, which I don't know whether Richard Smith would like to comment on that, because I think, Richard, you were part of that. But Richard or Angela, on productivity first and foremost?
Yeah, so I think productivity is, as you say, Krishni, something that is getting increasing focus because of the increasing workforce and resource, the NHS, and still the challenge. So I think, in community and mental health, there is less data that is comparable across the country, and that poses its challenges. I think, having said that, I think we've got natural opportunities across our group to look at that in different ways, and across the East Midlands Alliance, which gives us other sort of, if you like, benchmarking opportunities. But I do wonder whether we, as a board, should do in our board development or at some suitable opportunity a focus on productivity and how we can look at it, are looking at it, and actually what is it we want to influence further nationally on this.
I think that's a really good suggestion, Angela, because I think it's really important for us to all understand our organisational productivity challenge, as well as obviously the system perspective, which you rightly mentioned. Richard obviously sparked a bit of a discussion about this, but Richard and Paul and Anne would like to come in. So Richard first.
Yeah, just a couple of things to advise the board. There was an organisation called NHS Benchmarking that we're a member of, so we do get information on a regular basis across a range of operational services that allows us to compare with peers and take stock of where we are. We are seeking to be involved. There's some national work, we understand, around mental health benchmarking, because a lot of the work up to now has been very acute focused, as Angela was saying, but we have volunteered and are seeking to be part of that national work around mental health benchmarking. We think there is clear evidence, well, there is very clear evidence that demand across both community and mental health services has increased significantly. And although there has been some investment through things like Ageing Well and through the mental health investment standard, the demand is up very significantly, and that's driving some of the financial pressures that we've got. So we're very keen to understand how we are relative to others on that and be able to evidence the productivity. And I can't but praise a lot of the staff who, in response to the strong financial governance that we're operating at the moment, are looking differently at how they can deliver services. So we are getting a lot of innovation and productivity ideas coming through from operational colleagues.
It's really good to hear. Thank you, Richard. Paul?
Just picking on both those points, Krishni. I'm involved in a piece of work through the Healthcare Finance Managers Association that is looking at productivity specifically in community and mental health trusts to be able to draw together using data that we've already got within our trusts, trying as much as possible to keep it simple, recognising that we are about 15 years behind our acute trust colleagues in the richness and the coding that they have available to them, and certainly to be able to try and sort of measure that productivity over time as well, not just to be able to say where we are today. So as Angela pointed out, we can use that at the HFMA then about how we can influence NHSE to think and talk about productivity, mental health, community settings in a way that I don't think they've quite got the grasp on. So we're certainly doing it at a local level in the way that Richard has described, but also trying to influence region and national colleagues into how we think about productivity in our sector.
Thank you, Paul. Really helpful to add that perspective. Anne?
Yes, thanks, Krishni. I just wanted to share that the teams, operational teams, are really keen to embark on this work on productivity and really outcomes. I just went to the MSK Physio. They've got a development day this morning, and they're looking at how they work on the challenges of demand and how they develop their practices through quality improvement to get the best productivity and the best outcomes for people. So I think the teams are really engaged in that, but I'm definitely picking up from the mental health side and what Paul was touching on. We have the benchmarking and we're keen to get involved in the discussions. I think what we're seeing across all our services is that the pre-COVID counting on productivity is very different to the complexity we're seeing today. So actually we're measuring something that's very different. That's not necessarily in all cases saying higher illness, but the complexity of lives that people are living in and the networks they're living in and the pressures on people and probably the health concerns that we don't know yet from COVID that makes that productivity and capacity really difficult to measure. So we're really welcoming to be involved in those national sort of discussions.
Yeah, thank you, Anne. I think as Angela suggested a further conversation on this, I think would be really helpful for us to collectively kind of understand the challenge and the various challenges that colleagues have outlined, which sort of relate to data and changes in presentation, I think, and is sort of describing really. So actually, if time permits, I don't know, Richard, whether there's an opportunity at next week's board development, but it may be worthy of a conversation if time permits there, if not something that we can factor in for a later discussion. I'll bring you in anyway, Richard, because I think you were going to briefly mention the webinar yesterday.
Indeed, yes, just on the board workshop, of course, we've got an item later on the agenda that sets out the plan for the year. So as you say, if we can't fit it in next week, then we can certainly make sure that that productivity item does feature on the plan for the remainder of the year. Really good suggestion. Thank you. Yeah, just on the talking therapist, so we heard from one part of the talking therapist service earlier on in our meeting this morning. We heard from the new talking therapist health service yesterday at the member webinar, and this is one of a series of webinars that we're putting on for NHFT members. It was actually really well attended, and colleagues from the team came along and described the new service offer and shared some of the successes that the service had to date. Really, it's really making some positive impact. It was good also to hear about some of the future development plans for the service, in particular building partnerships with colleagues in the acute sector and primary care. As always, there's a recording of the webinar, which once we've processed it, will be available for everybody to view on demand, as it were, on the NHFT website. And encourage colleagues to do that. But yes, it was a really useful session actually to provide an insight into this exciting new service. So yes, I'd encourage people to watch if they get a moment. Thank you.
Yeah, thank you, Richard. I mean, I think what's powerful, it's sort of supporting people with talking therapies who have long-term physical health conditions. So it's really bringing that agenda together, which I think is incredibly powerful. Julie.
So I just wanted to go in on a point that Anne just made, linking productivity to quality improvement. I think it's really important if we're going to look at productivity that we do link it to quality improvement. There's a lot of work in the quality improvement training we do on productivity and bottlenecks and all sorts of things. So I think it's important that we do link the two together. That was really my point. Thank you, Chair.
Great, thank you, Julie. Well, thank you everyone for contributions on that. I think really useful discussion. So we really are obviously asked to note the paper and the report from Angela, and we've agreed that we'll feature productivity in a future board development session, even if we can't quite. We'll have a look at the agenda, but it may not be timely to fit it in our next one, but certainly an opportunity to look at that I think would be really important. Okay, so we move on now to two papers. One, paper H, which is our strategy update for Q1, and then the East Midlands Alliance Common Paper. Normally this would be David Williams, but in his absence, I think Paul Sheldon has ably stepping in. So Paul, over to you for both of those papers.
Thank you, Chair. Just taking the Digby Q paper first. It is a new style of report that David and Alison Gilmore have put together this time out. So this is the first airing of it. So both David and Alison have asked for feedback about how this paper links our progress on our strategy together. So it sets out the progress against all domains within the strategy. It also tries to map risks on what was the ORR and is now the board assurance framework together. We've still got a bit of refinement to do as far as that is concerned, but I hope again that the paper sets out how we're trying to link risks to strategy and vice versa. And that's, as I said, is being updated in and will be updated in the Q2 version. Progress at this point, Chair, is rated as green across all areas, and happy to take any questions on the detail within the paper.
Edith?
Thanks, Krishni. Thanks ever so much for that report. I really liked the clarity of how each of the Digby Q arms or legs or whatever you like to call it, tranches, are linked to risks. So that's fantastic. But I suppose having reflected on that, what came out for me was especially the grow and the quality, the areas for our strategy. The majority of the risks there are red. And I'm just wondering what we're signalling here. Are we signalling that, yes, it's a challenging environment and we know that, but are we potentially signalling a non-delivery of our strategy, or are we that there are risks that we're not going to deliver? I'm just wondering what the optics are around that.
I think in the first instance, Judith, it's tying the risk in. So I don't think the risks are any different to those on what was. These have been lifted from the old ORR, so I don't think it's a risk that we will not deliver our strategy. It's more about these are the risks that we are carrying within the organisation and how that overlays to the different elements of the strategy. So you mentioned grow, for instance. You can see there are 2 of 3 risks there, as you point out, are rated as red and as 20, but they are not risk we won't deliver on a grow element of the strategy, if that's clear.
Okay, thank you.
Melanie?
Yeah, just clarifying Judith's point then. The residual risk, or the use of the column residual risk, indicates that that's the risk at the end of the strategy having been applied. But it's not. So I just think for clarity, it would be useful to either remove the residual risk column or have a different one. We may not want to go down this road, but have a different way of assessing the level of risk that we would expect to be in place at the end of our strategic time period. One or the other. I think Judith's right. Just to have residual risk complicates what is impacting to deliver that residual in this particular document.
Yeah, I can see that, Melanie, and I'll have that conversation with David about how we take that forward.
Thank you. And I do think this is another thing we need to pick up as part of our conversation about risk more broadly, because this just goes back to the point about connecting, making sure our BAF is about risks to our strategic objectives and being really, really clear about that, which is the process of refresh I think we're going through. So at the moment it's presentational, but I think it needs to be more fundamental. Does that make sense? It's going to be more directly connected. I don't know if that's a fair description of where I think we are at the moment, but I think the next step in our development of this is just making that link more explicit, really. Tim?
Yeah, it's just for clarity, really, because and it's perhaps my naivety and just getting used to this reporting, but we report achievements to date and actions for the next reporting period. But we don't explicitly say we completed the actions for the next reporting period. Do the two absolutely align, or is it just how do we make sure that that is explicitly completed? That's what I was picking up on.
Yeah, I think that, and we're all getting used to this reporting, Tim, as we've not quite done it in this fashion before. So I think, again, another helpful comment for us to be able to refine this for Q2 to make sure that we are clear that we've completed those actions in the first quarter in this instance, and I think we can make that clear.
Thanks, Paul. Really good.
Thank you, everyone. So I think the report. I think it's fair to say the report is in development, and hopefully, Paul, you've noted some feedback to share with David and Alison, who are obviously are active in providing that reporting. I do think this just does connect back to our earlier conversation, though, about making sure that we, in our development of our BAF, that we're really clear about the link to the strategic objectives, and actually that is a follow-up conversation for all of us, as we've already said. So we'll take that forward in that way. But unless there are any other comments, I shall move on to the next item, which was the East Midlands Alliance paper. Then back to you, Paul.
Yeah, thank you, Krishni. Quite a lot in this report, which I think signals quite a lot of activity across the East Midlands Alliance. I'm certainly not going to go through it, but it does detail the activity under the 6 strategic aims of the East Midlands Alliance. I think there's been, fair to say, an increase in some of the professional bodies coming together across the East Midlands. One example, I was personally Ability, for instance, back in March, that was led by the Alliance. That was brought together and facilitated, but actually it's a really positive session about sharing, about learning from what others have started, much more progressed in certain areas. So and the paper details many other areas where that has been the case as well. Particularly as well, what the paper draws out is around the East Midlands Alliance existing as and progress over the last year or two has attracted a great deal of funding. And again, the paper sets out a number of areas where we've been able to attract external funding that we otherwise wouldn't have been able to have done, and that's been invested in the areas, again, that's listed out in the papers. And just one final point around a bit of details around some of the delegation that we're expecting from specialised commissioning and how that's progressing. Still a bit of a moving feast in some respects, but certainly around where we are with some of those conversations with the region. Again, the East Midlands Alliance is playing a big part in when some of that will be delegated down. It's not clear at the moment about when mental health, learning disabilities and autism delegation will come. It feels like that's not at least until 24, 25, but there are more conversations to take place before that's confirmed. And I'll leave that there.
Thank you, Paul. Any comments Any comments or questions? Robin, first of all.
Just to say, I thought this was a really, really helpful paper in terms of identifying the benefits and advantages of our participation on a regional basis. Just to pick out one, I used to be the National Commissioner for All Gambling Treatment in the UK, and it's really pleasing to see that through our participation in this, money has been secured for a regional service that probably would never have been provided in this region otherwise, unless it was done on a regional basis. So I think, you know, that example on its own makes the case for the value of this regional participation. So really helpful paper, and really encouraging to see how much money has been leveraged in through our participation. So very good. Thanks.
Thank you, Robin. Yeah, I think that's a really important point. Saki?
Yeah, again, very useful report. And the only thing I wanted to highlight in wearing my ICB hats, I've been commenting on how NHFT is involved in collaboration, and how this, especially with the running cost adjustment that's coming to the ICBs, is going to be really crucial over the next 18 months, and how ICBs also deliver their work, working more closely with system partners. I think it's a really exemplar demonstration of how it can work and deliver.
Thank you, Saki. I can't see any other comments, but yeah, I mean, I just wanted to really echo that, you know, for me, there's obviously a lot of really positive things in this report, but, you know, actually some very clear patient benefits as well, that, you know, reduction in waiting lists, which, you know, ultimately it's, you know, in terms of patient experience and the opportunity to access our care more swiftly. We all know CAMHS in particular was and continues to be a significant challenge in terms of tier 4, but, you know, reducing the size of the waiting list is a really important improvement. And I thought it was worth noting actually that of course we did cover that, you did very helpfully shared some of this with governors at our last Council of Governors meeting, because we felt it was really important to not just talk about the East Midlands Alliance in a very broad sense, but about the kind of actual, you know, benefits that have been delivered to our patients and our community in Northamptonshire, because of course, you know, I know governors would have been particularly interested in that. So really important. Thank you. Angela?
Yeah, just to say that I think, as people have said, I think it is a really clear demonstration of the value of the collaborative. We're still getting a lot of regional support to continue in this direction. I think it is seen as a really good model, and increasingly I think across other sectors this is being used as an example. So acutes being encouraged to think about how they can collaborate more. So I think, you know, mental health in particular has led the way in this regard. And I think the other thing to flag is that through the work that we pulled together with chairs and CEOs, which we will come back round to re-examine, there is opportunity, I think, for us to emerge more board sessions collectively across the East Midlands around actually how we take the next phase forward. So just to put that on everybody's radar, really, I think that is something that we probably need to connect on. We did some board development previously, but there's another opportunity, I think, to think about how do boards get together across a regional footprint to understand this population health approach. Thank you.
Thank you very much. Okay, I'm going to, I think we are at this stage, we're just asked to note that, aren't we, Paul? You're not asking us for any decisions or anything like that. So thank you very much, Paul, for presenting both of those reports. We move on to our people section. And I shall shortly bring Debs in, but I omitted to mention, and I do think it's important that we remember and recognise that Angela, our Chief Executive, was awarded a CBE in the King's Honours, and I think this is the first board since that's happened, so I just wanted to recognise that, because it's really, obviously, we all believe in completely worthy recognition, and I know there were lots of staff who were very excited by that, and thought it was really important as well that Angela was recognised in that way with a long career in the NHS. So I just wanted to take the opportunity to mention that. Julie, did you want to come in? No. Oh, we can't hear you, Julie, but I think maybe you were just trying to congratulate. I could see some
Yeah,
clapping
it
of
was
hands
I
going.
got react and raise around the wrong way. Yeah, thank you.
Okay, so I just wanted to mention that, which felt appropriate just as we're talking about people and we're going into our people section. So thank you, Angela, for your leadership and everything you do. I think we all recognise your huge commitment to the organisation, to the NHS and our community. Okay, so Debs, over to you for the people plan.
Okay, thank you. And hello again, everybody. So this is an update on progress on the NHFT people plan, which was included in the papers. By way of a recap, the plan was agreed by the board back in September 22 and outlined the Trust's people priorities for the next 12 months. I'm pleased to report all areas are progressing and a number are actually completed already. In terms of some highlights, because there's quite a lot to cover, I've selected a couple. So a piece of work that's already been completed is in the wellbeing work stream, and which is now adding value as we speak, and is an activity around neurodiversity. The aim of the project being to ensure neurodiverse employees are embedded into the workplace. And the sort of activity that this is covering, as you'll see from the paper, are dyslexia focus groups, manager toolkits, etc., to provide support. So this is an excellent piece of work. We're really proud to have delivered this. And I think in further recognition of that, to demonstrate what a great piece of work it is, as I think Angela alluded to earlier, the Trust has received a nomination for a HSJ award for this piece of work, and also an HPMA award for Healthcare People Management Association. So we're up for 2 awards. So it's really something to be proud of. One of 3 award nominations that I think are going forward from across the UK. So that it's really a good piece of work. I think the reason I wanted to highlight it is because it's a great example of EDI awareness and support being embedded into day-to-day activity, which is as it should be. So I think we can use this as a role model then for other activity we have going on. So obviously we've embraced support from our networks and colleagues. So it's a really good success story, and coming back earlier to using real life stories, I think this is something that we can definitely highlight and use again as a case study. The other example I'd probably draw on of work that's progressing is around compassion conferences. And I think, those of you that could attend, we've held 1 conference already. This is one activity that's happening as in support of the development of a compassion culture, which I think everybody's very engaged with. We've held 1 conference already, which was held successfully. We have a further conference that's scheduled for September that we're on track to deliver. And again, I just wanted to highlight this because this is a great example of collaboration between teams, in particular HR teams and communications, coming together to ensure that we're embedding compassion into all our leadership behaviours. We've got lots of examples. I think I'll probably stop there, because please feel free to ask questions about other things that have been highlighted. But just to confirm and bring that back to the loop of, I think we mentioned earlier, the new strategic workforce group. Implementation of the plan will now be reviewed bi-monthly at that group, which is working well and will ensure that we continue to be on track. I think, again, coming to the new national workforce plan that's landed, there will be further activity, and we'll have to see what crossover there is with what we have in place already. But that's being ICS led at the moment. But I think we'll anticipate coming back to the board once we know it and we're a little bit clear in terms of what that activity looks like, but that'll be at a later date. I think that's pretty much it. I'll stop there, and obviously any questions.
Thank you, Debs. Really, really helpful. Thank you. Let's bring people in. Saki first.
Thanks for that, Deborah. A question on the National Work Plan. And obviously it's early days, but some of the new roles of the apprentice, I guess the way it's being badged up, apprentice doctors and apprentice nurses, etc. How is that going to work at a local level? And we had a presentation from University of Northamptonshire at the governor's meeting last week, where they're going to be, I think, partly involved, but I just wanted to know what we have at a local level and when we think that's going to start in advance of the 2030 target.
Yeah, I think the good news is we've got lots of activity happening already in this area, and I think that's probably been the thought so far, just with colleagues, when I've sort of delved into, so how far have we got, you know, what can we pick up from this? So I think there is a feeling that we've got great activity happening, lots of progress being made, but I think the truth is we need to understand what this means actually in reality for us, what it means for the system, living, breathing this in the team currently, and what that actually, if there's anything new from it, etc. So I think, if I might say, it's just a little bit early. It's literally just landed, so we're just trying to take stock. It's in the middle of leave period. I promise you, it's not an excuse because we're all really excited. But I think in summary, there is lots of activity. It may be we're doing lots already. It feels like we have really good representation, you know, that you know, certainly in all the forums I attend, there's a real recognition of the value of apprentices. We just need to understand what this additional support now that's coming down nationally will mean for us locally. But I don't think we're able to say that just yet. Sorry, that's not a great answer just at the moment.
No, thank you, Deborah. I think that just represents the reality, isn't it? To be fair, I went to the Regional People Board, and we had so all the CPOs or all the systems were represented around the Midlands region, and there was a presentation about what was in the long-term workforce plan, but a lot, you know, there's still quite a bit to be worked through. What does it mean? But I think the key thing is that is the point about building on what we've already done and what we've already started. Certainly a big plank of it is on retention, where there's been a significant focus for us as an organisation. So I think there is a bit more work to be done for all of us to understand the detail of some of the strands of proposal, and certainly regional colleagues I know are working on that, and I'm sure we'll be doing that as well within our own system and within our own organisation. I think the general message from the Regional People Board was thinking just about, you know, what can we do at regional level? It's going back to sort of the earlier point about collaboration, really. What can we do at regional level? What can we do at system level? And what can be, you know, what's best done at organisational level? And building on structures that we've already got, which and work that we're already doing in some instances. But I think a really exciting and interesting opportunity ahead. So thank you, Debs. Julie, did you want to come in on that particular point?
Julie, did you say, or
Yes.
Julie?
Julie.
Yeah, go for it, Julie.
Thank you, Krishni. Yes, so Saqib, in answer to your question, we've had nurse apprentices at degree level and nurse associate level, probably for definitely pre-COVID. So I would say about 5 or 6 years. We've had them in the trust, and at the moment we've had our first lot qualify, and it's been a really good programme, and we've had some really good feedback on it. And I've met several of our staff who have been through that programme who are now qualified nurses working with us.
Great, thanks, Julie. Okay, a couple more comments or questions. Judith and then Julia. Judith first.
Thanks, Krishni. Sorry, Julia, you seem to have...
Oh, actually, I think Julia put her hand down, which was that's probably why you fell out of order, Julia. Should we let her go first, Judith, as she was obviously keen? Julia.
Actually, I think when you speak, it takes your hand down. I'm learning. Oh, thanks, Krishni. Thanks, Deborah. Great report, and really good to see some of the initiatives supporting staff, etc. For me, the success of those is absolutely going to be making sure that all our managers, all our team leaders understand, you know, how to support people in an individual capacity. Great to have programs, but how that then reflects to individuals. And just as a little example, at a recent governor induction session we had a great conversation about how to recruit people as an anchor organisation in a community from different groups, youngsters, and we talked about people with living with neurodiversity, and how some very simple things at recruitment as part of our processes, different approaches would make things incredibly more positive and have better outcomes. So I suppose it's about translating some of these projects into what it actually means for a manager sat in a recruitment process or supporting a member of staff. And I think that'll be the measure of our success. But great start, and really, really positive to see the focus, I think, on supporting people in that way. Thanks.
Thank you, Julia.
Krishni, can I just come in on that just very quickly, because I think it's relevant as well to apprentices. I do think, and going back actually to the talking therapies, the power of the videos and scenarios, if people are willing to, you know, sign up to sharing something like that and perhaps putting it out slightly more in the public domain is going to help us massively. So I think over time we need to bank some of these success stories, because there's nothing like a real life story. And even if people are willing to talk to other people as well about it, go as far as that. It won't be for everybody, I appreciate, but I'm very keen to do that in all of these work streams and consider whether that's possible. I just thought that was worth mentioning.
Yeah, and I think it's a really important connection to what we discussed earlier, isn't it? Because actually it's, you know, Natalie's story was very, very powerful, because, you know, she basically lived and breathed the power of involvement, empowering people to develop services and having the chance to influence what we do, and why that feels important to staff. So actually really powerful. Judith, and then finally Linda, and then I do probably need to close this item. So Judith.
Thanks, Krishni. Debbie, thanks very much for presenting that report. Really, really positive. I really just have two observations and not questions. One is that just reflecting on my experience from a number of other boards outside the healthcare service, it's really, really heartening to see that we're continuing to support our staff, you know, emotionally and practically, and that's part of our plan and part of our strategy. And I can tell you that that's just not the case. That's where companies, you know, seek to make, you know, immediate savings. So that's just fantastic to see. And secondly, I'm also really interested to see the work that is going around the tackling racism from patients, because clearly this is something that I've talked about before, and you know, I'm still in touch with staff who've mentioned it on service visits. So really, really good to see the changes in the strategy in relation to that. Thanks very much.
Thank you, Judith. Finally, Linda.
Thank you very much, Krishni, and thank you, Debs, for a really good report that you've presented. I just wanted to add on the various things that have been highlighted in the report, and what Debs was alluding to, the continuing work that's happening in all these priority areas. In particular, that for us in NHFT, when I've certainly gone into various forums with colleagues across our system in Northamptonshire, they've asked us to talk to them and also share the work we are doing around Together Against Racism, the reverse mentoring that was done, the workshops that we've had, and also the continuous work, and that we do have those conversations. So in other areas, they actually struggle to have those open conversations and actually listen to some of the experiences of the staff who are working with them. Compassion, and certainly the work that our HR learning and development colleagues have supported to then embed that as a golden thread across the organization. So previously we mentioned the work that we did at the Nursing and AHP conference in May, and that has continued to have outputs because the team are actually doing more bespoke work with teams on the ground. So the part of managers being confident and competent to have those conversations, that support is ongoing. So I just wanted to add that. Thank you, Chair.
Thank you, Linda. Really good to hear about the sort of ongoing work from the conference, which was very successful. Thank you, Debs. I think you're just asking us to note the progress and the assurance that's provided through the report. So thank you very much for that. Okay, welcome back everybody. I make it 11:30, so we'll make a start. So we continue with section 10 of our agenda, which is our people section. And I welcome Beth Brandt, who's our Freedom Speak Up Guardian, who many colleagues will have had the chance to meet at our recent board development workshop, where Beth kindly took us through the reflection tool. So Beth, over to you. I think you wanted to cover a little bit of the content from the annual report, but also the new strategy. Thank you, Beth.
Thank you, everybody.
It'd be great
Hello.
if you could leave a little bit of time at the end for questions. So if there
Okay.
are any comments, thank you.
Okay, perfect. So the annual report, hopefully it was well received. It's been a busy year. So there's some recap points. I'll put the summary at the end. It'd be interesting for you to tell me at the end of this session whether that summary, that's what I think was important to summarise, whether you felt that there were some other key areas to bring out into that summary. So the concerns continue to increase. That's good. We like to hear how our staff are so that we have an opportunity to help and support going forward. We have mandatory training. So we're one of few organisations that actually have our Freedom to Speak Up training as essential. There's lots of organisations that are hoping to join us in that, but we're one of few that have that, which helps our staff to understand that speaking up is important, that they have that induction. Our percentage in compliance is always above 90%, so that's really positive. The number of concerns we're seeing now are becoming more open. So that's also a bit of a testament that people feel that the process is safe. So that isn't always the case, which is why we focus our work on detriment and disadvantage within this organisation, and we added it to the policy last year. We also want to let you know that all of the patient safety concerns are appropriately signposted. Lots of work that we're doing with Debs and her team in HR. Really helpful that we've got the resolution policy. So that will really help our colleagues to have an idea of whether it's an informal route or a formal route. So hopefully that will really help. The other area that recruitment have helped with is the other area that HR have helped with is the new recruitment process for managers, to ensure that we've got a clear process for all managers at all levels for appointing in a fair and transparent way. So that's really helpful, and that came as part of the Speaking Up. Even though HR had got it on their agenda, it helped us with the feedback from staff to talk about the difficulties that they have, or they felt that it was an unfair process or a little biased in some ways. Of course, the recruitment ambassadors will help our process and our journey as we go forward. We continue to work collaboratively with LPT. They've just initiated a questionnaire and an evaluation tool of what staff do know about speaking up. So they're going through that journey now, and hope to use that in NHFT so that we know that staff do know that speaking up is the right thing to do. It's about anything that gets in the way of delivering good care. It isn't just patient safety, it's everything, which is why we have the categories that we do listed by the NGO. And I think that's all I've got on the annual report that I wanted to share with you, other than the feedback. Sorry, we have changed the feedback for Q4, that people using Microsoft Teams, people have an opportunity to use an anonymous version. And we've asked, as part of that evaluation and feedback, that we are collecting the demographic information, and we're also collecting their ideas for innovation and improvement. So it really gave us a really good flavour of what staff are feeling through that process, some really positive experiences and still some work to do. So that's all I've got to share with you on the annual report. So if I can take any questions at that stage, that would be great.
That's super, Beth. I think it's a good moment to pause and just let people explore anything that they would like to. So I could see there's quite a few questions or comments coming in, Beth. So first of all, Melanie, please.
Hi, yes, Beth, thank you. Excellent annual report, and another really good insight into the comprehensive and broad strategy and approach and support that the Trust puts in place. to enable staff to feel that they can speak up freely. You asked us whether we thought your summary at the end was comprehensive or hit the right notes. So I was responding to your call to action. The only thing that I think you have probably underplayed in the summary is you mentioned the work that you've done in collaboration with Leicester Partnership Trust, but I know that you do more broad collaboration and work engaged with the regional networks and the National Guardian's Office, and I don't think that comes out in the summary quite as much as it should do. You know, a couple of examples of things you've done in that space to add to the summary would be just a further kind of way of reinforcing the work that you do outside of NHFT.
Lovely, thank you. Yeah, noted.
Thank you, Melanie. Judith?
Thanks, Krishni. Thanks, Beth, for another really fantastic report. We've had quite a lot of discussion around this already, so it's more of an observation. A couple of weeks ago, I was fortunate to go to the NHS Providers Governance Conference, and freedom to speak up was something that was specifically referred to quite in depth, actually, at one of the opening sessions, specifically in relation to how the information from Freedom to Speak Up Guardians and reports is really the soft intelligence around quality within the trust. And the fact that we are so focused on this is just fantastic. So it's just, I just wanted to triangulate and pass that information back to you, that NHS Providers is now talking about the importance of freedom to speak up. So thank you for all you do. Thank you.
Brilliant. Perfect. Thank you.
Thank you. Saqib?
Thank you. Great report. Just a couple of questions on the pie charts at the back, where I think question 5, where it says, do you feel your concern has been addressed? Where if you add the no and the partially, and obviously that's 58%. So I just wanted to know how that fared. And then on the ages under the age range of feedback and gender, is that also reflective of NHFT overall, with 60% being 46 to 55? So it seems to be it's an older age group that are willing to speak up. And then the gender, the 9-10, is that similar to NHFT overall as a population? Thank you.
Okay, good questions. The first question is around the first question you just said.
It was whether you felt if you add no and partially together, it comes to 58%, to more saying that they didn't think it was overall dealt with.
Okay.
Dealt with.
And what we're looking at, so we've changed the report, we've changed the evaluation following last feedback, because I don't know whether that is from the Guardian or whether that's from when individuals are signposted on to other areas. So what we're working on at the minute, so we've changed that feedback. So for Q1, we'll know whether it's from the Guardian or whether it's wider from signposting, which will be really helpful. Also working with Debs and LBT to ensure that we have a schematic process for speaking up, whether that be somebody speaking to me, to Angela, to HR, to the business partners, with some time frames and some templates of what our expectations are when people share their concerns about speaking up. So I can't ask any more than that, because I'm not sure where that was within the process. When you ask about, I've already identified, so we're looking at breaking down the barriers. We're trying to do some targeted work on who's speaking up and who's not. So we're working with the apprentice team to understand actually whether there's enough champions within that team and what the barrier is for young people speaking up, whether we need to be looking at different ways of promoting freedom to speak up. And the other area is people are speaking up in that middle range. That is very similar to other organisations within the region. That's what we expect. Majority of the staff come from a registered nursing background and are of that age group.
Okay, thank you, Beth.
Thank you.
Is that okay, Saqib answers your question? So I think there's a big focus on barriers, isn't there, and how we encourage perhaps groups who are less evident in speaking up to make sure they've got vehicles for doing that. So I think that's the point you're making, Beth, which is really important. Tim?
Yeah, Ben, I absolutely love this report. Some of the data in particular harks back to my days in the John Lewis Partnership, where the numbers you're generating are very similar to an employee-owned business. So real credit due there. There was one number, though, that just really stood out for me, which didn't compare favourably, which was, given your experience, would you speak up again? And we're just over half saying yes, the rest saying maybe or I don't know. That's English for no, basically. I was a bit disappointed that that number isn't higher. If we're going to focus on anything, going back and understanding why they wouldn't do it again would be really rich territory. But it's a really good report, really great data, and gives you real area of focus. So well done to you.
Thank you. And it's right. When I read that, I have to think about speaking up as the organisation, and when we equate that to the staff survey report. So that's the other question that we've changed to say, would you speak up again to the Freedom to Speak Up Guardian? Because what we need to be sure on for the Guardian's role, would people speak up? What then happens after I've signposted people out? So yeah, well questioned, really. Thank you.
And I think the other area, Beth, is just, whether detriment is a factor, isn't it? About whether people feel that they suffered in some way as a result of speaking up, because obviously that inevitably, Tim, the answer is going to be no, isn't it? If actually you felt you experienced something negative. So I think you're doing quite a bit of work on that as well, aren't you, Beth?
I think if I just pick up on that before we go to Julia, detriment and disadvantage is really, really hard. We've talked about it in the Guardian and in the regional office, and people say about it being somebody's perception. It may well be their perception, but it's generally their reality. So we have to listen to what they're saying. So my big objectives, focused, targeted objectives in this year is detriment and disadvantage. Have we got the process right? Do people understand that we don't tolerate it and it's within our policy and process of what we do if people tell us about that? The other targeted work is looking at all of the protected characteristics and breaking down those barriers as to what do we need to do for the certain group, so that we know that everybody has an opportunity to speak up and to share their concerns.
Thank you, Beth. Julia?
Thanks, Krishni. Beth, yet another superb report. Thank you very much. Really important. It just shows us why we need to see an annual summary for the work that goes on behind the scenes and the types of things that are raised. And I know we look at this in Quality and Safety Committee in quite a lot of detail. And I know we drill down into lots of different areas, but just to say, from a patient and staff safety point of view, we've experienced in that committee some of the examples of where things haven't gone well at all, and you've absolutely been on it. I wrote down here dog with a bone, but I thought perhaps I should just say you're persistent. But you were you on behalf of the staff and the patients, you go back. You don't take no for an answer, and that's a huge quality. You do that with compassion and respect for the staff and the patients and people at the other end of some of these issues. And without people speaking up, there's no way that we will improve our safety and staff experience. So thanks for a great report, but the outcomes, I know you've got lots of things to work on next year, but the outcomes for me really, really significant. Thank you.
That's really kind. Thank you. It's a big job, and dog with a bone, you're absolutely right. I have to step back, and I could only do it actually with Krishni and with Melanie and Angela and Dave. That actually gives me that bit of, and Debs gives me that bit of sense check that's like, right, enough now, enough. So, which is really helpful. So thank you.
Thank you. It's important. It's an important persistence and resilience in this role is really important, isn't it? Angela, probably appropriate to bring you in at this point.
Yeah, I recognise that description. So I think, yeah, really important to say a big thank you to Beth and our champions, actually, because obviously we've got them as well, which, help to build this safety and quality culture. And as CEO, I've always said that I want more concerns being raised than ever. And actually, I take comfort in more coming forward, to be honest. And that's, I know not everybody's perception of it as a CEO, but it's certainly mine. Really important work that Beth is doing. And just to remind people that, Beth meets with myself and Dave very regularly to do that, so that she feels supported, because it is a tough job. It is difficult to manage these types of concerns. And also Krishni, Melanie and myself also meet regularly with Beth as well, to make sure that we are as ever, trying to look at what more we can do, but also to make sure we are triangulating as much as we possibly can across the organisation. But no, thank you, Beth. Really, really positive work. Thank you.
Thank you, Angela. Richard, finally.
Yeah, thanks, Beth, for the report. I was just thinking, we talked earlier in the meeting about industrial action and the potential impact of that. Is there anything you think we need to change in our process to kind of capture potential impact for that, or do you think our existing processes cover any concerns that people might have?
I think Debs is probably better to answer that question than me. I haven't had anybody talk to me about industrial action other than before the plan was to strike, and how people felt a little bit, I feel guilty if I do, I feel guilty if I don't, and I'll worry about a divide. And that didn't come to any fruition through me in any of the speaking up concerns. I think they're all directed really either to Angela or to Dave or to Chris and Debs.
Thank you, Beth. It's a really interesting question. I don't know, Angela or Debs, would you have any comment on that? I guess that shows how we've responded collectively to the industrial action, and I hope that means that we've not been divisive in the way that we've managed and supported people to cope with it. But
yeah, no, I think, Krishni, exactly as you said, I think that of course people were worried, and quite right, they spoke about that, which is great. But again, credit to colleagues who've been planning this. It's been done, I think, with great thought, planning, inclusion, and as I say, nothing's come through me in terms of concerns following any implementation at all. It's more about obviously managing it, but that's different.
thank you very much. Okay, Beth, do you want to just then talk briefly about the strategy and just tell us what you'd like from us in relation to that?
I could, if you don't mind. So I attached in the appendix an action plan. So it's an action plan stroke strategy for NHFT. So it's basically our document that sets out our journey to embedding speaking up into everyday practice to ensure safety for workers and outstanding care for our patients and families. So I've used we had the National Strategic Framework that was provided by the National Guardian Office, which got the four pillars, which is your workers, your leadership support, freedom to speak up Guardian, and what we're doing within the system. So I've had some feedback. So I just wanted to share with you very, very quickly just the feedback that we've had. It's important to say that I raised it with the interim head of office at the NGO, just to say this is if all of our workers and leaders do all of this, and these are the actions that we take place as part of our reflection and planning tool, then we can help together embed a really good speaking up culture within NHFT. So I shared it with them, and they asked just to put a couple of responsibilities in for the board. That was just receiving the Freedom to Speak Up report for me to present on that, and to review our responsibilities under Freedom to Speak Up every 2 years, which we've done through board development workshop. So if I just share with you very, very quickly, there's very few changes. Whilst I'm sharing this, it's important to say it's a big document and it's quite wordy. Can anybody see my mouse waggling? Can we see that document? Yeah.
Yeah.
Okay, so it's really helpful to this is what our journey was. So it wasn't particularly clear on what we were aiming to do. If I did it as a slideshow, that might help, mightn't it? From the beginning, might be easier. So we've got the pillars here of what we expect our staff to do. And then on the sector, you can just see the changes. I've added the title. I've added in about trust board. We've talked about the triangulation, the patient and staff experience, and presenting the reports to the governance committees. So then on the next slide, very few changes, but we have a really good trust and local induction on Speaking Up, that Speaking Up is included within there. Notwithstanding, I get lots of queries and concerns about induction, that people still feel a little bit left, even though we've got a buddy process and we've got induction process. So that's just something I'm working with organisational development on. I've said that the policy is in, and the policy includes the detriment And this guide is quite wordy and quite lengthy. I'm working with colleagues that are neurodiverse and may receive this in a different way. So we're trying to simplify a process for both the policy and for this action plan. So that's what that red was here. Attending training for speaking up, listening up and following up. So that's the non-execs and non-exec leads. So I'd really, really urge all of you to complete that listening up and follow-up training that's mandated by the National Guardian Office and Health Education England. We've put that on our own ESR, but I'm happy to share the links as you need. There's also, we receive the National Guardian Office newsletters, so I'm planning to share with you the newsletters on a routine basis as I receive them, so that you're up to date with the national changes for Freedom to Speak Up. Sharing the Freedom to Speak Up action plan as priorities with our DMTs, execs, clinical exec boards, so that everybody's on the same page of what we're trying to do. Continuous professional development for myself, so the NGO refresher training and attending the conferences, and offering peer support, as Melanie said, outside of LPT buddy process with regional and local, and I'll add in national. Looking at benefits of speaking up, I've added in ensuring retention and development of staff. It's really, really key. We want to keep our staff and we want to develop them, which link to obviously our police day conversations and our exit interviews, but I hadn't put that in there. And KPI, instead of just staff metrics, I've put staff feedback metrics, and I've added in the Guardian quarterly feedback from staff speaking up.
Great.
So that is the document. If it's not clear, I'm happy to explain either outside of the meeting today, of course.
Lovely, Beth. Thank you very much. Is everyone happy to endorse the approach? Because I think it's heavily based on actions that we've already identified to address improvements in speaking up. Is everyone content to do that and endorse the overall approach? There might be points of detail that we can work on outside of the meeting, but I think it's a great piece of work, Beth, and I think you have full board support for it. I think the important point here for all of us is recognising. Beth, I think we can see your screen, by the way.
Has it gone now?
Yeah,
Sorry.
it's gone. It was only that it had gone into your inbox, so I was just conscious that there might be things in there you didn't want us to see. Right, thank you very much, Beth. Really good to hear from you, to receive the annual report, and I think the support of the board for the approach to take things forward.
Thank you for your support.
All right, thanks, Beth. Thanks for joining the meeting.
Take care, all.
Bye. Great. We move on then to, very appropriately, to our quality section. So we start with the assurance report from Robin, I think this time, who's chairing the meeting. So Robin, anything you particularly wanted to highlight?
Well, I'm assuming that everybody's read it, so I won't take any amount of time in discussing this. It is important to know that there is an alert there in relation to the waiting lists for ADHD and ASD services, because of the levels there are there. That's covered at various points in this agenda as a whole, so I won't put any more detail on that. In terms of the advice, the one that I really need to make clear is that, strictly speaking, we should have had opportunity to approve the infection control report at our last meeting, but because of the pressure of time requiring it to be submitted, it wasn't considered at that meeting, although we had a verbal update, and it comes instead to this meeting. So Judy will be talking about that very shortly, but the Quality Committee in August will be looking at this again then, so it will receive all the scrutiny it requires, really. So I won't add any more to that, other than to say that because this committee does, of course, look in some detail at the Freedom to Speak Up, we do commend this at the bottom of this report, because Beth's work on this really is exceptional. So we're ahead of you in terms of all the praise that we've been giving to this. I'm happy to take any questions in relation to this report.
Thank you, Robin. Any questions or comments? Notwithstanding Robin's point that I think we're going to be picking up the ADHD point later on, aren't we? One thing I just wanted to clarify is we got the I think we got the annual organisational audit, which related to medical. Am I right in thinking that was the medical revalidation again?
Yeah.
And I think we did have that previously, didn't we? And were there some updates to it
Yes.
which resulted? So I thought it was important to note that, because we have seen it before, and I think it's changed since we last saw it. So is that right, Robin?
Yeah, it wasn't complete. So we requested quite a few updates to it to cover particular themes. That's why it's not fully covered off yet.
Okay, but are we happy to note the updates here? Does it require further scrutiny at Quality and Safety Committee? Can I just check that?
That was the plan. We were going to, Julia, I need to check with you. I thought we were going to look at it again, so we can't, not really in a position to approve it yet.
Okay, Angela?
Yeah, I just want to say in relation to the ADHD, ASD waiting lists, this is obviously something that's not just peculiar to NHFT. It is beyond us and part of a national picture. Just recently, we shared more information in the system exec in terms of this, because we felt it needed to go beyond NHFT because it is a system concern. So that was helpful that that was shared recently. In addition to that, we're also working across the group to understand that, to recognise if there's any innovation or transformation that we can and should be doing and sharing. And we're also gathering information across the East Midlands Alliance and Midlands and East trusts to understand that position as well, and getting information ready for the national director on this. So there's a lot of work going on to influence and recognise that this is something that is not an NHFT issue, albeit we're experiencing it, to influence other people's focus and attention on it as well.
Thank you very much, Angela. Julia, were you going to come in? Oh, no, not. Okay. Or Banu wanted to come in. Yeah.
Yeah, I just want to update about the annual organizational audit. We have had the system back in place, because for a while it wasn't recognizing, or it wasn't allowing the appraisals to be signed off. Now we have got them in hand, and we are meeting. I mean, we have completed that 85 of the appraisals have been signed off. So I'm happy to provide any updates if needed now, or for a separate meeting that Robin was suggesting.
Okay, can I just check what Julia or Robin want to do in relation to that?
I'll defer to the chair and see what she thinks, Julia.
I think we were just going to have it back for like a final complete summary was all, wasn't it? Because I think first time round there wasn't anybody to present it, which is why it then came back the last time. So if you're happy with that, that's fine.
Yes, that's absolutely fine. I think that's right. Yes,
For completeness.
The paper had come. That's right. It's
That's
helpful
right.
to remember, Julia,
Yeah,
that the
yeah,
paper had
yeah.
come, but unfortunately, it wasn't. There wasn't an opportunity to discuss the detail within
Yeah,
it. Okay,
yeah,
so
yeah.
if we refer it back to you for a little bit more scrutiny on it and
Yeah.
assurance, I think that would be helpful.
Yeah.
Great, thank you very much. Thank you, Robin, for the report as well. Julie, then on paper M, the infection prevention and control report.
Thank you, Krishni. So, as you know, annually I bring a statement to Public Board in relation to infection control to say that we are in line, we are compliant with the Health and Social Care Act and the Code of Practice for Infection Prevention and Control, and we always accompany it with the annual report for infection control. So it talks about the year that we've had and our plans in terms of the action plan for next year, and that's the bit we will take and discuss at Quality and Safety Committee. Quality and Safety Committee hear on a regular basis about infection control since COVID, and we've continued, even though we're not just talking about COVID. I give an annual verbal update every meeting at the moment as the DIPSI. Now you will see in the S-bar We talk about there are some areas within the BAF, and you'll see in the annual report some pie charts on the BAF, that we are partial compliant in some areas, but we feel this doesn't affect our compliance. It's just there are areas that we indicate that we want to do more on. These are just small areas, but they will enhance our IPC standards in NHFT. So that's really all I want to say. Thank you.
Okay, thank you, Julie. And I'm sort of, I think the assumption must have been when the covering report was written that it was going to have been scrutinised by a Quality and Safety Committee, but that it doesn't sound like that didn't happen. So whilst I think, you know, it's obviously it's been submitted, hasn't it, Julie, or it will be submitted because of the deadline that's required. I think the plan, from what I understand, is it will be reviewed in more detail at the next meeting of the Quality and Safety Committee.
Yeah, that's the plan, Krishni. We just felt that we couldn't really put my statement out without something to back it up, really. So this is the evidence to back it up, but we do want to have a discussion in Quality and Safety Committee like we would every year.
Yeah, okay, thank you. So any questions on it from a board perspective, or any points that we would like the Quality and Safety Committee to look at in a bit more detail, which might be a helpful way of thinking about it, as that's the next step in this. Otherwise, everyone content to just delegate that back down to the Quality and Safety Committee to explore it in more detail. But broadly, I think, Julie, you're saying we are compliant on the requirements. There are some improvement opportunities which you've highlighted in the report, which can perhaps be explored further.
I always think when we do these self-assessments, we're always quite hard on ourselves as an organisation.
Okay.
That's good practice. Yeah.
Okay. Thank you. So we note that it's been submitted, and we ask the Quality and Safety Committee to explore it further at the next meeting. Thank you. If there's nothing else on that, we move on then to the patient safety report, paper N, which I think is over to you, Linda.
Yes, thank you, Krishni. I will take it that the report has been read. It is quite a lot. It is quite a long report, and I just wanted to assure Trust Board that this report has been scrutinized in detail and presented last week to the Patient Safety Committee. Of note, this report is key to the organization because this is where we demonstrate that we're being open. We also demonstrate what we do with regards to any incidents that happen in our organization, how these are managed, and what is also of note is how we learn from these incidents and what we take forward so that we can prevent those. We've highlighted the top 5 safety issues that have been picked out over the period of 6 months, and also put in information around what is happening with regards to these areas. Of note, you will see that throughout the report, we've also included some information that supports the understanding of why some of these reports have increased and actually what we are doing around that. We also note within the report that when it comes to NHFT, we have a really good reporting culture. So whilst the reports, the incidents themselves may look like, oh my goodness, we've got a lot of incidents reported. What I'd ask the board to note is that for most of our incidents, there's low harm or no harm that has been reported during this reporting period, and that's highlighted on page 1 of the report. Further on within the report, we've included information on learning from deaths, which is very key. And to highlight, there have been no further deaths from COVID-19 during this period that we are reporting. We've also included information on LEADER, which are the deaths for people with a learning disability. And again, none that are highlighting NHFT, but we take part in the process because we work with system partners, and that's how our LEADER process is then developed. We've provided within this report information on the work that's done on a weekly basis, and sometimes even more than weekly, where we need to then meet outside of our usual internal assurance meetings, where all the incidents are discussed, scrutinized, and from there, We then look at whether or not this will be a serious investigation, a concise investigation, and more so that some of these incidents have gone into our ongoing thematic reviews. And again, we've provided updates on those ongoing thematic reviews. I'm pleased to report that for this period that we're looking at, May through to June, there have been no breaches for duty of candor. At the last board, we were reporting on previous breaches, but that's something that we've been able to report that we've not had those. So really positive work from the teams insofar as ensuring that we have no breaches, and assurance to the board that we are being open, we are speaking to relatives, patients when there's been an incident that has occurred. We've provided some information to highlight what we're doing around our patient safety strategy and how this ties into the rollout of the Patient Safety Incident Response Framework, our PSIRF, the group that's working, and also the system group that we are part of, which is mobilizing for implementation and rollout of PSIRF that is due to come into being next year. We know that for NHFT, for most of the things that are required through that, we already have those in place. So we are in a good position with regards to that. I would ask boards to then note at the end of the report where I've put in the proposals that we're asking you to be assured around the work that we are doing, to also have further assurance that the information that we are reporting is being scrutinized in the various committees that we've mentioned, more so that we presented to Patient Safety Committee. We have this information also looked at within our Quality and Safety Committee, and we're asking you to note this information that is being presented. I'm happy to take any comments or questions.
Thank you, Linda. Julia?
Thanks, Krishni. Thanks, Linda. Really good report. And I know, just for those that don't know, I'm part of the safety committee, and it is a huge level of scrutiny on all of it. Two quick things to just mention, if I may. A couple of things in there with outstanding practice. One was around medical devices, and the medical devices lead has put in so much work over the last year to move us to a position where we can truly say we are assured that our medical devices are managed, tracked, serviced, and staff are trained. So that's a huge journey from a year ago. Just wanted to mention that. And around the pressure ulcers, which is, as Linda's put in the report, one of the top 5 safety issues. Tissue viability nurses did a fantastic presentation about a huge piece of preventative work they're looking at undertaking. And that, combined with our quality improvement group with Leicestershire Partnership Trust, I feel things might well be moving for pressure ulcer management and outcomes for patients. So really significant assurance we took from the meeting. Thank you.
Thank you, Julia. Melanie?
Oh, I'm not sure if I was next, but I'll grab the opportunity. It's actually interesting, Julia. I note and take a lot of assurance from your commentary about the pressure ulcers. I actually had a technical question, if you mind, point of clarification, understanding. I note in the report, as we get into the sort of the graph section in the appendix, the increase in new category 2 pressure ulcers, which seems to be a really upwardly mobile trend line and getting into the top of our tolerance area. I wondered what the relationship was between category 2 and category 3, if there's a progression between the two, and whether an increase in category 2 is a brewing storm, if you like, for category 3 or 4 ulcers. So just because I'm not being a clinical expert, I'm not quite sure whether I could interpret it that way, or whether that's just a category 2 pressure ulcers are dealt with and we don't have to be concerned about that uplift.
I think I think if I understand it, it's like whether it sort of flows from one to the other, so that
yes,
in effect, once you've got a high number of one, does it flow?
Yes.
So Linda, do you want to try and very briefly answer that if you can?
Yeah, so thank you for that, Melanie. So when it comes to pressure ulcer grading, the grading doesn't change, and that's to do with the fact that actually when we see them at when they are graded at 2, that's actually a better grading, because when we get to the 3 and ungradable, that's that's worse even for the patient. So when we pick them up here, what you'll notice that even the plans put in place and the recovery around that is far much better than for the patient. It's when we get to 3 and we are then reporting those into, so our 3 ungradable are then reported via safeguarding as well, whereas our level 2 and below, we do not report. So actually it's good work on the team when we are picking them up earlier and putting in those interventions. But certainly the gradings do not change. Otherwise, we'd see a situation where the ungradable then changes the ungrading. It doesn't change the grading.
So do I see, so just my understanding, so if you have a category 2, it's dealt with as a category 2, it clears up, it never progresses.
So if it did deteriorate further, the grading would not change. But what the team would do is the management would change. And from that, we would then have to report it into safeguarding, and it may then come back into our IAMS process, but the grading doesn't change. It's actually a review of that impact and harm and how we manage it. That would be different. I hope I've been able to clarify that for you.
I think that's really clear.
Should I draw any concern from the increasing trend in category 2 pressure ulcers, which doesn't have a commentary in the patient safety report against it, I don't think.
Can we, rather than, I think
So
we could
happy to take that offline and,
can we take
and
that,
pick it up in quality and safety would actually be an appropriate
yeah.
place to delve into that particular discussion. Thank you, Linda, that was clear.
Okay, thank you. Angela?
Yes, helpful report. Thank you, Linda. But just in terms of the escalation of news, which is good that that's been picked up as further training and thematic reviews, etc. But just in terms of assurance, are we confident that that is being acted on, even if that other work is going on through our operational services, that they understand that is important and escalation is expected, even if we're going to come back and look at, you know, a review of this? Obviously, it's important that we're acting on that in the moment in patient care.
It's okay for me to come back in, Angela. Yes, that's something that is being taken forward. We continue to monitor around our news performance weekly. We do that through our triangulation early warning signs. So that is work that we are looking at and continue to do so.
Okay, thank you very much. So I think you're really just at this stage asking us to note the assurance that's been provided and clearly, you know, the management of the risks around patient safety and management of investigations and the framework that's in place. So, and I think helpful that obviously Julia and I think occasionally Robin, if Julia's not present, kind of making sure that patient safety committee is covered by a non-exec as well because of the importance of this area. So thank you. We note that if everyone's happy to do that. So finally in this section, we have paper O, which is workforce safeguards. Back to you, Linda.
Thank you, Krishni. Again, I'll take it that the paper has been read and provided a lot of information and updates with regards to our workforce safeguard. Just to assure the board that the paper would have been presented at the Integrated Assurance Committee meeting. So that was the first time for us to present there. And it has been reviewed with subsequent changes, updates made for Trust Board. So for those who were in the Integrated Assurance Committee, if you see any changes, it's because it's further updates that have come through. We've highlighted any new risks and how these risks are being mitigated. We've included information on workforce, which information is also scrutinized when we go through our performance on the integrated organizational performance report that is being presented within the organization. So again, further scrutiny with regards to that information. What we did want to be able to highlight within this report is around the areas where we've had increased usage of non-regular staff, agency staff, and just to reassure board that there are plans in place to then reduce this and also to mitigate with regards to the quality and safety of the service that's being provided to our patients. We've also asked the board to note the risks that we've included in this paper, and I'm
Linda, you accidentally went back on mute, I think.
Yeah, I just
So-
noticed that the mute button had come up.
Yeah,
Sorry
I think we
about that.
only literally just missed the end of your comment, which was, I think you were asking us what you were asking us to note.
Yeah, so what I was asking Trust Board to note is the increased usage of non-regular agency staff, and that we do have plans in place to mitigate this insofar as reducing that agency spend, and also with regards to the quality and safety of the service that's provided to the patients. We've also asked you to note the risks that we've included in the paper, and that these are being mitigated with further assurance that this will be scrutinized further within our integrated assurance committee, and also that there's the ongoing oversight within the organization in the various meetings that we've discussed so far, including our workforce groups that we have.
Thank you, Linda. Any questions on anything within the paper? Everyone content to note the update from Linda. Okay, thank you very much, Linda. We move on then to our finance and performance section, which is section 13, and we are initially first report is from Chair of our Audit Committee, Saqib, on paper P. Saqib, anything you want us to draw to our attention?
Thank you. The three things I was going to mention were the Involvi payment, so the analysis that's being done into that, which will hopefully have feedback at the end of September as to seeing what the process will be, so we stay HMRC compliant. The other was on anti-crime, so the 230k up to 230k fraud that's still being investigated. So we don't know how much of that is fraud or whether it's just been recorded incorrectly, but that's being investigated. And then the limited assurance on the violence and aggression, which was an area that we knew was being investigated, and we will take learnings from that. So they were the three main things that I wanted to pull out, and also the green that we achieved on our counter fraud. So thank you.
Thank you very much, Saqib. Any questions for Saqib from any of those items? No. Okay, thank you very much. So we'll note the areas that you brought to our attention, Saqib, and including a positive practice that you've highlighted there. So thank you. And then over to Judith for paper Q, which is the report from performance.
Thank you, Krishni. In benefit of time, I will not go through the different points that were discussed, which are under Assure. The two specific risks, obviously we look at all risks that are pertinent to Performance Committee, but the two specific risks that we spent quite time discussing during the committee was B8, the financial risk, which we've already touched on today, and also Q6, the excess demand resulting in patient being unable to access community health services. And there was discussion focusing as to the need to escalate this issue to Northamptonshire ICB. If I may just go back to the advice section of the report, there are two areas where the committee felt was important to escalate to the board, because the committee will be ongoing monitoring the issues. One is in relation to the trust financial report. Clearly, our financial position was discussed in quite a lot of detail. The committee specifically focused on what we all felt were the most important risks, which was the impact of the fourth wave of the COVID pandemic, and the need to break even financially, and how these two interact with each other. We are very focused on the careful management of finances, but also we discussed the need to ensure that this was through a clinical lens, and Richard gave quite a lot of assurance and detail around that. The second point was around digital maturity assessment, and this is at ICB level. The ICB, although has a digital lead in place, they need to continue to work on their not only strategy but also the impact of the scores of which is brought on by the acute trusts, and how they're going to work through that problem. There are two areas that I'd like to draw the board's attention to, which is around celebrating outstanding. One is a congratulation to the hard work and dedication of the finance team, which needs to be recognised specifically in relation to the strong value for money report that we received from our external auditors. And secondly, in the successful launch of the Northamptonshire Care Record, specifically with our digital team highlighting a security issue in relation to patient data, which has now been resolved. And these words mean nothing to the amount of and the depth of work that was involved in this, but also specifically highlighting that there's a digital academy which has now been set up in order to provide on-job digital upskilling for our staff, which has been specifically recognised as really the only way to go, because if it's not on job, it's likely to be either forgotten. If you don't use it, you lose it. So that is the report from the committee. I'm happy to take any questions arising.
Thank you, Judith. Any questions or comments? I was particularly pleased to see our digital maturity assessment score. I think these are all new, have relatively recently been published, haven't they? And it was good to see that NHFT had reached a joint highest score in the Midlands. I thought that was a really positive achievement. So congratulations to everyone involved, and indeed all the other points of recognition that Judith made, which are absolutely important for the board to acknowledge. So thank you, Judith. Right, I think we're moving on to item we have would normally have an annual update from the Northamptonshire Health Charity at this meeting, but for a variety of reasons it wasn't possible to get. We have in the past had the director attending, so I think as you are one of our trustees on that board, I wondered if you could, and particularly in Dave's absence, comment on where the charity is and when might be a useful time to have a feature update from the charity.
Thanks very much, Krishni. I'm absolutely very happy to update board. Number of things have been happening at the charity. It's in fact been quite a busy time. From a governance point of view, there has been a new executive director who's been appointed. His name's Jonathan McGee. He's actually come over from Addenbrooke's Charitable Trust, so has experience. Apologies. He has experience in running quite a large NHS charity. His background is marketing and communications, so the charity is currently looking at how best to support him in areas where the team and his skills leave some gaps. There's also been a new chair that's been appointed, and many of you will probably know. It is Sushel Ori. He's the new chair, I think almost as from in a couple of days' time, from the 1st of August. So there might be some changes in relation to that. The charity is probably going to undergo some form of governance review, and certainly Jonathan already has some ideas on changing governance. From a financial point of view, the charity has suffered quite a lot in the current financial environment, and there needs to be a review. I'm sorry, I don't have latest figures. My figures are something like 4 or 5 months out of date now, so apologies, I can't provide that today. But the charity needs to very carefully review how it manages its investments in relation to meeting its overheads, which is in the past been paid out of investments, but in the current environment, that's not been possible. So that's one of the big challenges facing Jonathan, amongst a number of other things that he wants to also tackle. I think a proper update from Jonathan may be more pertinent towards the end of the year, sort of October, November time, November perhaps best. That's what I would suggest. Thank you. Happy to answer any questions, by the way.
Thank you, Judith. So perhaps we can Richard Smith, I'm kind of thinking we should plan for a November update if maybe through Dave and Judith we can secure a commitment from the new director to attend. Does that sound like a...
Yes, we're in dialogue behind the scenes on along those lines. Thank you.
Great, thank you. Okay, good, thank you. Thanks, Judith. We'll note that. So we finally, in this section, we have the integrated organisational report. In Dave's absence, I think Anne will take the lead on this, and I'm sure supported by other colleagues. So Anne, over to you.
Okay, thank you, Chrisney. So this has obviously been a developing report over time, and it's really good to see it evolving and bringing in much more information to triangulate for us as a trust. I'm going to take the report as read because it's quite a large report. The main things I was really going to pull out was around the sort of the concerns or the potential risks for us around operational performance. So firstly, the wait list, we're seeing quite an increase, and I think all of our services are incredibly busy, seeing an increase in activity and referrals. But what's been promising is that in the last period, 91% of those received treatment within 18 weeks, which is always that balance of trying to manage increased demand and productivity, as we were sort of discussing earlier. So that's promising to see, but something to keep a real watchful eye on. And the waitlist committee has a lot of detail around each of the potential areas of concern and action plans around them. So actually, the areas of concern that the waitlist committee bring out are in here. So the MSK, we know we've had a considerable issue over time with the waitlist. They have been doing a very bespoke piece of work around their productivity. They've had an action plan pulled together, done a lot of QI work about how we sort of manage this large group of people, which has had a real impact really of the effects of COVID and then the elective care surgical work that was done in a big sort of promotion through NHS England, which then had lots of people come through onto the wait list for physio. So a real sort of storm of activity following COVID. But that work is ongoing. As I said, the team's together today and we're seeing a real improvement, as you'll see in some of the charts, and we're tracking that through SEB every month. Children's ADHD, we obviously spoke on this previously. ADHD and neurodiversity is a really big discussion point nationally. Every day I'm getting communications from different areas about how are you managing, what can we do to improve. I think what I found promising in here that we're seeing overall CAMHS improvement of 40.2%. And we're doing a lot of work around the fact that we know we have people waiting, and how do we manage that in a supportive, compassionate way, and the work that the teams do on contacting families, giving other community offers to support while waiting for their specific work. But I think children's ADHD is something that we've talked at length in different committees and is very much a national discussion of how do we improve this for our families nationally. Mental health out of area delays are another area of risk for us, and what you'll see in the work is an area of huge improvement. The teams have worked incredibly hard at bringing people back into county, and that's been really important for our flow and the people being near their families, and the importance of that in their recovery journey. We are still at 0, but it is the demand fluctuates, so we're managing that as tightly as we can, and the recovery plan that's wrapped around that continues and is very much focused on length of stay. So I think they were the main highlights that I wanted to pull out. I hope don't know if any of my colleagues have got anything they saw in that they'd like to add, but I hope I've done that justice to what Dave would want to have said.
Thank you, Anne. Really comprehensive. Any questions or comments, Scott?
Yeah, thank you, Chrisney, and thanks, Anne, for taking us through that. I'm just reflecting on the developments in this over the course of the past 12 to 18 months and where we were circa 18 months ago with what we felt was quite a good tool at the time for our performance dashboard. But this has completely moved us on quantum leaps forward in relation to it. Just trying to reflect on what it is that we're looking at. I know that might seem, to sort of draw the board's attention. We are very close now to having a whole organisational dashboard And that's an incredibly impressive thing to be able to say. You know, we're so close to having that at our fingertips, evidence of assurance right across all of our organisational areas. A very, very powerful thing to be able to say. So we obviously have placeholders in the document for when finance will be included. I think that's the bit that I think we need to be able to complete. And at that point in time, we might not like the answers it's giving us in every area, but it's at least assurance because it's giving us, you know, a proper business intelligence driven answer in a number of areas. And I think when we get to that stage, and it feels like we're on the cusp of getting there, we should be sharing it with others, because this is a powerful tool that I think would benefit not only us as an organisation, but other NHS organisations in the way that they manage their operational data as they go forward. So if there was a question in the midst of that, Krishni, it was how long is it going to be until we have the finance element included? But, you know, I might have been directing that more at Dave rather than Anne coming in to sort of cover that on Dave's behalf.
Thank you, Scott, and helpfully Richard anyway has got his hand up. There is some there is in the covering report some financial information which I think is useful to draw people's attention to. So it'd be useful for Richard to comment, I think, on Scott's question. But I think clearly, you know, I found it quite interesting looking at the deficit drivers at month 3 in the covering report, because it does highlight sort of some things which are, you know, challenging, aren't they? Because they're not completely within our gift, I think, Richard, if I'm reading that correctly. And we do need a sort of strong sense of focus and granularity and being able to evidence those, because for example, inflation, we were very clearly asked to follow very specific inflation assumptions. If I'm reading this right, we're seeing a 0.6 million difference in what we planned for. So Richard, over to you.
Yeah, no, thanks, Krishni, and thanks, Scott. And yeah, and I was going to come in there. We have included for the first time some headline figures, and we talked earlier in the meeting about the risk of getting to break even, and hopefully the sort of areas that we've included are useful. So it's helpful to get that feedback, Krishni, that some of those is helpful for people to see. And yeah, we need to focus on the areas that we can control and influence. At the same time, we have completed some returns so that the centre can review things like industrial action costs as well. And obviously we've got new dates announced, so that will be an ongoing pressure. Yeah, so the plan is to work for the next report to include more of the financial detail. We need to work with Dave and his team, and you know, welcome feedback at that point on whether we're including the most useful information. Obviously, finance is a byproduct of a lot of the other indicators in here, particularly pay, given that's more, you know, more than 70% of our costs. And actually on non-pay, we've done some interesting analysis that shows actually in a number of areas we're spending less than we were in 2016 on a variety of things, medication being one of those. So that shows a lot of progress that's been made over time. But yeah, we're looking to do that for the next report, given the focus on the finances.
Oh, that's really helpful. Thank you, Richard. I do like seeing the deficit. I do like seeing the drivers of deficit, I think, in that very summarised way, because it's helpful sort of headlines for us to understand what's how that's breaking down. I mean, clearly there's an efficiency under delivery that is something that we need to be grappling with and thinking about how we address. But some of those other issues, it does look harder to manage, and being cited on those, I think, is important. Robin?
I was going to say, supporting Scott's point that this is getting really close to being this comprehensive report on all aspects of who we are and what we do. And it sort of belongs earlier in the agenda rather than right at the end after we've spent such a long time on so many other matters. And I just wonder whether just some placement thing, it really ought to come towards the start, because it covers and highlights all the areas that then we might like to, we might pick up in other agendas. So it's just a suggestion.
Thank you, Robin. We'll certainly reflect on that, and might be an opportunity, I think, to think about that as part of our board effectiveness review. So I can see Richard nodding, so we can certainly reflect on that, because there's always an opportunity to think about where the structure of our agenda. So helpful feedback. Tim, brief point from you.
Yeah, I mean, I think I echo a lot of the comments about finance, that we're all kind of, our concern is about how that's going to curtail activities later in the year, as we're going to have to dive for the line. So, and I know a lot of this, from personal experience and from what we're hearing here, is out of our control. So what are the variables we can still control as part of the value work stream? And then how does that change our glide path, Richard, for the rest of the year? I think that's going to be a real concern for us. I know it's not specifically here, it comes later, but in terms of the reporting, that's highlighting it. And I think that's our worry, is that it's going to start restricting other activities we can deliver on. So that's all I was going to say.
Thank you, Tim. Yeah, helpful observation, I think. Okay, if there's nothing further on the organisational performance report, I think at this stage we're just asked to note the report and obviously the risks that have been highlighted. And I think some of those things we can, some of the observations, as I said, that people have made, I think we can pick up as part of our discussions, ongoing discussions about how we improve the effectiveness as ever, as part of continuous improvement approach in relation to board effectiveness. Melanie, I was just going to move on, but I can see her hand has come up. So
it's only a quick one. I was reflecting on this report and thinking that in actual fact, it would be useful to have this report included in the committee papers, not necessarily as an agenda item, but referring back to this organisational dashboard strikes me as having some useful content, easily accessible and interpreted content that actually plays into quality and safety, performance, and even the Integrated Assurance Committee. So again, just something to take away, maybe, Richard, and think about how we can make this report available to all the committees that would delve into some of the dashboard style content. Thanks. Sorry.
Okay, thank you, Melanie. And Richard, I think, has commented in the chat that we can consider that point. Thank you. So we move on then. I think that's all the items we've got in section 13. So we've now got a number of fairly short items, I think, that we just need to cover off before we conclude our meeting. I'm still aiming for 1 o'clock, everybody, so I challenge you to make sure we cover these things kind of efficiently. So first and foremost, paper S, which is the staff flu COVID campaign. So that's over to Linda, please.
Thank you, Krishni. I'll take it that the report has been read by board members. And just to say that this report is being presented so that we can provide you some assurance on our plans for flu and COVID campaign and delivery for the forthcoming year, as well as sharing our reflections and learning from the previous campaign in the previous year. We've detailed within the report what went well and areas that did not go well that we will be taking forward. Of note to the Trust Board was an appreciation from the flu and COVID group that's established within the Trust for the support that has been provided and the exemplar role modeling that has been demonstrated by our board members who all received their vaccinations. So thank you very much for that, and looking forward to further support. We've highlighted the areas that did not go as well as we would have liked them to have gone, and have noted the areas that would then like to look at for this year so that we can make improvements on those, including refocusing and re-energizing our commitment to safety, why it's important to have the vaccinations to keep ourselves safe, our colleagues, our families, and the patients that we come into contact with. So that will be the main focus, as opposed to looking at other things that we'd focused on previously. It will also be important how we engage staff so that as long as we have the buy-in, good myth busting is done, then we're likely to see an improvement in our performance. Of note, we've made sure that we are keeping on top of this, because it is one of our sequins. Not only do we want to achieve the sequin, but actually we want to keep people safe, and we know the impact of colleagues then going off sick with COVID and flu. Huge support to our colleagues from IPC as well as our occupational health colleagues who are part of this group, but also provide the continuous support outside of the campaigns itself. So thank you to those. A huge thanks as well to mention our pharmacy colleagues who have already ordered our flu vaccines and have been doing some proactive work insofar as us ensuring that we are then able to provide vaccinations to our staff, including for COVID. So that's the main highlights of this report. Happy to take any comments or questions.
Thank you, Linda. Any comments or questions from board members? I think just a reflection from me, really always good to see reflection of learning, lessons learned from the previous campaign and what we can do differently to try and improve our performance. And it is a little bit disappointing because for such a long time we were a really good performer on flu vaccinations, weren't we? But I think as the report reflects that perhaps over the period where COVID vaccinations started becoming more high profile and necessary, we've struggled a bit, I think, to keep our high level of performance on flu vaccinations. So I'm very supportive of the lessons learned, and also sharing learning from other trusts, which obviously is very important. But I'm sure we would all support the proposal as presented by Linda. So thank you, Linda. Okay, we move on then to a couple of papers, well, 3 papers in fact, I think, from mainly from Richard. So I'm going to let Richard do the talking on these. Richard, I think first of all, paper T, which is the external well-led review.
Thanks very much, Krishni. Yes, if I could refer colleagues to paper T in the pack. It is time for us now to consider commissioning our next external developmental review of leadership and governance, and this is in line with NHS England guidance. This paper then sets out the approach I'm proposing that we take to that. We are planning to spend some time next week at the board workshop exploring this further, where we'd already planned to talk about well-led anyway, so that would inform any specific key lines of inquiry we may wish to take beyond the core requirements in the guidance. So subject to the support of the board, we would then look to explore the potential for a joint commission of an external review with our colleagues at LPT as part of our group model approach, and then seek to engage an appropriate supplier via a procurement process later in the year. So really, I'm just seeking the board's approval in principle to that approach, and we'll spend some further time next week going through the underpinning details. Thanks, Krishni.
Thank you, Richard. And for sort of newer colleagues, it's worth saying that this is just in very general terms, that this is something that we've routinely done in the past, but of course is separate from the CQC well-led inspection. But we chose and agreed with NHS England that having had a well-led inspection at that particular time, it wasn't felt absolutely necessary to do this, but it's regarded as good practice. And clearly we haven't now had a CQC inspection for some time. So the opportunity to reflect formally and get some feedback and external reviews always helpful. And I think the idea of working with LPT on this makes sense and feels very appropriate because we can share learning together as well. Melanie?
I guess my only question, I absolutely endorse the approach, and the paper was really clear, Richard. Thank you. You took us through the sort of the logic and proposed approach that you intend to take. I'm just considering that this is money, and money is short, and therefore looking for just a confirmation of the necessity. I absolutely understand the reason why we should do this and the good practice that it represents, and I understand that it's an NHSE requirement, but given the current economic situation, I'm wondering how far this is an absolute necessity, just based on the money, nothing else. So that's my question.
Yeah, I don't know if Angela or Richard want to respond to that. I mean, I do think we should explore it. I think that's the first thing to do, and I think, you know, and that money might be a factor in the decision. Clearly, we want a value-adding, efficient, cost-effective way of doing it. And there are some options, I think, including peer review options, which we might want to consider, which could be value-adding, but still relatively less, you know, costly, of course. So I think at this stage, my take on this is we need to explore what's possible. And if we choose not to do it for a variety of reasons, then it's the comply and explain principle comes back into play is what I would sort of say, really. But I think we are duty bound to explore it because I think it's been some time
I
since we've
understand the
done that.
exploration. I guess it's just the next step then will be for an options appraisal and recommendation to come back to board in due course, which I think it's just helpful to understand that.
Yeah. Angela, do you want to add anything to that?
Yeah, I think that's just literally covered it, really, is that we need to explore it. We are expected, but as Melanie quite rightly says, we want to make sure that's as value for money as it can be, and all of that has to be in the options. But I don't think not exploring it is an option. We have to.
Yeah. Okay, thank you, Angela. Richard, finally.
Yeah, I mean, I very much support that. I mean, recognise point Melanie is saying, and I'm grateful for, you know, we need to challenge every penny that we're spending to make sure we are getting value. But I'm conscious we haven't had one of these for quite a while, and we're in a very challenging leadership environment. We know the difference that makes. So I definitely support exploring this.
Thank you, Richard. That's really helpful. Thank you. Okay, so I think you have the board's endorsement, Richard, for the approach that's suggested. So we can take it forward on that basis. Back to you then on paper U.
On the effectiveness review, yes, thanks very much. Given that we've spent some time on this, the development workshop, again, I'll keep this relatively brief. So you'll see set out in the paper what is a very good overall effectiveness review score for the board again this year, which is pleasing to see. In addition to the individual numbered scores, which you can see set out in the paper, I've included some positive comments. There were lots and lots of positive comments actually, but these are just thematic indications of the areas in which people were particularly satisfied with the work of the board over the past year. Through the development workshop in June, then, as colleagues will know, we took the opportunity to explore and reflect on the feedback and the results, and identified 4 areas of continuous improvement, which again are listed in the report at the bottom of the second page. And I've then expanded on those areas on the third page in terms of how we're proposing to take those forward. So again, really, I'm just asking for the board to formally receive the outcomes of the report, as of course our discussion was in a development workshop, and we'll happily then take any questions or comments on it. Thank you.
Thank you very much, Richard. Scott?
It's just a very brief comment. I mean, Richard, first of all, you know, I agree with your summary. It's a very strong report, you know, and I think the human eye tends to go to the areas where the scores are a little bit lower as a consequence of that, but our low scores aren't, I would suggest, troublingly low. I just wanted to make a comment in reference to my comment of a few minutes ago, and you know, I think going forward, I would look at our score in relation of the benefits of business intelligence. I would hope that would go up as we go forward, particularly when you look at the quality of things like the, you know, integrated organisational report that we've literally just reviewed. And I just think a frame of reference about what we interpret to be a business intelligence needs to think about it in that fashion, you know. So that was all. I'm certainly happy to support the report and the recommendation you're making, Richard.
Thank you, Scott. I mean, helpful, I think, because that obviously that was a development that we've been striving towards to get that report. So hopefully that will be part of the improvement that's reflected in future scoring. But it is in our nature, Scott, to keep looking for opportunities for improvement, and that's not a bad thing. So it's a positive focus, albeit we do need to, as the report highlights, celebrate our success, which I think we have done through the course of this meeting. Some of the many positive things that have been highlighted. So thank you, Richard. A really good report, I feel. And as you say, I think you're just asking us to record and receive the outcomes of that in this board meeting, as we should in public. to demonstrate we've undertaken that activity. Okay, we move on then to paper 5, which is, sorry, paper V, going Roman there, which is the annual board development work plan. Richard.
Super, thanks there, Krishni. Yes, and again, as a bit of a link, really, board members reflected positively on the development plan that we implemented last year. So really building on that, we've put together a plan again for this year. So just to highlight that board members will see a number of the core development areas that we've agreed previously should feature each year, and in addition some more bespoke items that we've selected for this year based on where we are. As will probably be obvious from looking at the table, we haven't fully planned the remainder of the year as we try and remain dynamic and flexible to what's topical and coming up. And indeed, we had one of those items earlier in terms of productivity, which we'll now be factoring in. So really just again asking for the board's support for the proposed approach at this stage in the year, accepting that it will remain dynamic. And again, I would ask that people, if they have any ideas or suggestions for items that could be included later in the year's plan, please to let me know. The only other thing I wanted to highlight in addition to the NHFT aspect to the report is that we are working in conjunction with colleagues at LPT to explore joint development opportunities. We've certainly taken the opportunity to work together on things like Together Against Racism, which proved really successful actually last year. So as we move forward, we'll be looking at similar opportunities to collaborate with colleagues in Leicester. So thank you very much.
Thank you, Richard. And I guess sort of picking up on our earlier conversation, there might be some opportunities in relation to the well-led developmental approach that we, not want to do jointly, and then there might be learning or development coming out of that we need to do jointly as well. So so those are all opportunities we should explore. So thank you, Angela.
Yeah, I was going to say, Richard said it already in terms of the LPT. I think as a group we said we would come together once or twice a year to do that. So I think we just need to, if we haven't got the topics, signal that in the paper. And then the East Midlands Alliance one that I referenced earlier, we just need to think about that may also be future bits. So how do we start to build in strategic alliance development as well as board development is something we probably just need to start to think about how we're framing that as part of the well-led. Thank you.
Yeah, it's a really important point, Angela, because and of course it takes some planning to do those things. So we need to sort of think about that quite early on in the piece, don't we, to try and get dates and things fixed up. So yeah, I think those are two really important reflections. Richard?
Yeah, I was going to say, is it a board and collaborative working development programme? Angela and I are obviously in the same wavelength today, but just to signal that is where what we're trying to strengthen, isn't it? Not just our own danger. It looks a bit inward looking.
Yeah. No, I think it's a really powerful point. And of course there could be, Richard, you'll be pleased with me, I'm going to bring it back to money here as well, that there might be things that we find more efficient to do together, particularly if we're actually thinking about bringing in somebody external to do some training with us, for example. So so there might be some benefit from a cost point of view, but also from a developmental point of view to do some things together where it helps. So I think good points to note, Richard, for and kind of incorporate within our plan. Certainly, I think we've said LPT, we talked about East Midlands Alliance, and there might be other opportunities actually from a system point of view, which we might want to talk to colleagues in the ICB about with what we do together, because it's been some time for where all boards have come together within the ICB, so we might want to think about that as well. So perhaps we could add that into our proposed approach, Richard, just for completeness. Thank you. Otherwise, I think we're supportive, and note the sort of nature of the programme, which is obviously to be flexible and to take input and feedback from colleagues along the way. So if there is anything else you think of, please do share that with Richard and myself, and we can look at that. So for now, Richard, I think we're just approving the proposal with the amendments or suggestions for strengthening that we've discussed. I move us on then to the paper W, which is the LPT and NHFT joint highlight report. I did chair this meeting of the last of the joint working group between us. I think I was going to draw our attention anyway to the joint quality improvement priorities, but I think Julia mentioned that earlier in the meeting. Actually, it was really good that there are these joint quality improvement priorities which are highlighted on in the detail of the report: pressure ulcer prevention, care and treatment, recognition and care of the deteriorating patient, and mental health, safe and therapeutic observations. And I thought it was really exciting that we were really sort of had selected three very clear areas that we were working on together, and looking for shared opportunities for learning and improvement, which felt really positive. And the other thing I was just going to draw to the board's attention was the recognition that obviously we're both involved in the Provider Collaborative Innovators Scheme, I think it's technically called, and therefore naturally we felt it was relevant and appropriate for that to be featured in our joint strategic priorities, because we would be working together on that. So those are the key points that I wanted to highlight in David's absence from that report, but happy to take any questions if I can, or if there are any. Julia?
Thanks, Christine. One really, really quick comment. Number 4 in the report talks about the trust round tables, and we had needed to just say what a superb innovation, getting clinicians together from both organisations to look at an area to address, and the fact that they were bringing in external national experts to help with this was phenomenal. So I know it's in there in the paper, but when we heard about it in the meeting, it really was very innovative and really positive for the future. So thanks.
Thank you very much. And it's a good reminder that obviously Julia and I attend that meeting together with Kathy Ellis and Faisal, who is Kathy's deputy over at LPT, along with obviously executive colleagues. Excellent, thank you. So we're just asking you to note that report. And then finally, we have the annual health and safety report, which is paper X. And over to you on this.
Thank you, Christy. I will take the paper as read. It's quite a lengthy report again, but it just is giving you the annual overview of the health and safety within the last year. This report has circulated other committees, which I think is important, and we've just reviewed process around this. Over the year, what we've seen is quite a development in the team and in process, and really very much around, we've had a number of set meetings and programmes put in place to support the work that is recorded in the report. So that's around the measuring ourselves against standards, which will be reported later to board when it's due for our standards to be reviewed from health and safety, but we are progressing really well with those. Also, we have a set EPRR standards, which are sort of part of health and safety, about how we respond and keep people safe, and they're also being benchmarked at the moment, and we are progressing with those. We've had quite a development within staff safety, and a staff safety group has been implemented during this period, which talks to the really the violence and aggression piece, not just physically but verbally, and also looking at the racial aspects. So these are things that have been put in place to really understand a lot of the information that we're seeing, and to be able to make sure we monitor, make changes and develop. The staff safety group has now developed a lot of the plans and the policies around protecting people, and that's now out in process. And we've also, as the teams develop, we now have a staff safety officer, which is a really important development in that area. So as much as I leave all the individual sections, which I can take questions on if people have questions, that's kind of like the underpinning of what's happened during this year that supported our health and safety work in the trust.
Thank you, Anne. Any comments or questions? I mean, this is a really important report, so I don't want to sacrifice the opportunity for some comments on this, because I guess there will be, because there is a sort of quite a stark, the data is quite stark, isn't it, on violence and aggression and verbal abuse in particular. Melanie.
Well, I just wanted to support Anne really, because she gets a complete grilling at quality and safety every time on this report, where we do delve into the detail and have had some quite in-depth debates as well, and updates around the violence and aggression and some of the areas of the report that really challenge staff well-being as well as staff safety. So I just wanted to reassure the board that this is regardless of what time we have left, Julia is on abound always to give us adequate time to delve into the detail of health and safety, and it gets good debate at quality and safety.
Well, that's very helpful, I think, to have that assurance, because absolutely would want this this whole, you know, it's an absolutely significant area for all of us, and our collective responsibility around this room to make sure that our staff are supported with this. So really good to get that assurance. Richard.
Yeah, I suppose we tend to focus on the areas for improvement in these type of reports, and I couldn't but notice the big jump in. I have all the equipment needed to perform my duties safely. I know there's a similar question in the staff survey where we score very near the best on that, but we should take account of that and try and find another way maybe to follow up with staff who are raising that as an issue.
Is that something, Anne, we can leave with you to consider as part of the
absolutely
the staff safety group?
Yes.
Okay. Any other points on this? Okay, I think so. Thank you very much, Anne, for presenting this really important report. I'm really pleased that we've looked at it, albeit time was a bit tight, but I'm very pleased to get the assurance from Melanie about the level of scrutiny this area gets as well, as part of the Quality and Safety Committee. So we take the report, we received the report for assurance purposes, and ask you to just follow up on that question that Richard has raised, if that's okay. Great. Thank you very much, everybody. So we have come to the end of our formal business. We have the Declaration of Interest Register available for obviously for public scrutiny, but also for noting at the board. I have no other business that I was particularly asked to pick up at the beginning of the meeting. So unless anyone indicates anything urgent that needs to be covered, I propose that we close the meeting, but would like to just take the opportunity to ask for any brief comments, if anyone wishes to, on the agenda. Certainly reflecting on the board effectiveness review, I think we did have quite a lot of discussion quite early on, actually, about some quite big issues. It might not be particularly strategic per se, but certainly big issues like productivity were aired, I think, following Angela's report. And I think we've certainly celebrated some very positive things. So I particularly wanted to pick those out. Was there any other feedback? I think helpfully Robin commented about the positioning of the integrated organisational report, so we'll consider that as well, I think, as part of that. Anything else that anyone wanted to comment on? Angela?
Just to say that I think the Alert, Advise and Assure reports are just really working well. I just think I find those really helpful, and just, you know, I don't know if others are finding that, but I think it is really helping in terms of the discussion and the information.
I agree, thank you, and I've shared it with other people, actually, so now it's being adopted in all sorts of other places, because actually, and to be fair, I think we learned, we took the format from someone else and adapted it to our needs, but it's great that other people are sort of saying, actually, because I think it's crystallizing, isn't it, for us, what we need to bring to the board's attention, which I think is really important. Julia?
Just to build on that, absolutely, as a chair who writes some of the reports, it focuses you down to what we really need others to know, and that is really important. Definite improvement, and really welcome. If there's things we can improve with style and content, then let us know as chairs. But absolutely echo that, Angela. It feels much more robust. That's really good. Thanks.
Thank you, everybody. Well, on that very positive note, I will close the meeting. Thank you, everyone, for your contributions.